Uh, E.V. Raman, sir.
Yeah, you're starting.
Okay. Doctor, so before your talk, we'll give just 2 minutes tribute to Dr. Lata Mangeshkar. So that will be running from Hall A, and after that, your talk will be streamed from Hall B, Doctor.
Thank you, thank you. You go according to your plan. Okay, I'm
Yes, yes. I just wanted to inform you that. Yeah.
Perfect, perfect.
Okay.
Yeah.
Welcome, dear delegates, to day one of our scientific program here in Hall B. We begin with an instructional course on managing pediatric airway by Dr. E.V. Raman sir, who is a consultant ENT surgeon at Manipal Hospital, Bangalore. Delegates are requested to post their queries during the session in the chat box, which will be addressed by sir at the end of the session. Over to you, sir.
Morning. I need to thank the organizers for giving this opportunity, for sharing our expertise or whatever little we have of it in managing the pediatric airway. We shall go through a plethora of conditions and basically concentrate on the tips and tricks that you need to do for better outcomes. I run the Children's Airway and Swallowing Center at Manipal Hospital, Bangalore, and we've had about 2 decades of experience. Now, what is the objective of this particular instructional course? We are hoping that you'll have a better understanding of the anatomy, the physiology, the airway pathologies, airway instruments, and overall management of the airway, along with a few tips and tricks for common procedures. Now, as far as anatomy is concerned, we all know that the pediatric larynx sits much higher and more anterior in the neck. And the adult larynx is shaped differently from the pediatric larynx. The pediatric larynx is conical, and these anatomical differences are important. In the adult larynx, the narrows diameter is at the level of the glottis, whereas in the pediatric larynx, it is at the level of the cricoid cartilage. In the current day and times, we not only assess the airway, but also the digestive tract because of the intimate relationship between these two. So we have to assess the airway, we have to assess voice, we also have to assess swallowing. And when you have an endoscope or some instrumentation in your hand, or you have an imaging technique, you must make sure that you are assessing both the airway and the digestive tract. So the concept of management, holistic management of the aerodigestive tract is very important. Now, what are our concerns? It's respiration, voice, feeding, and importantly, we need to find out what is the site that is involved. As far as stridor is concerned, that is, these are the symptoms of the respiratory problem. You could have stridor, you could have snoring, you could have inspiratory stridor, you could have expiratory stridor, you could have biphasic stridor. All these things have to be noted down. As far as the voice is concerned, we need to find out whether it is muffled, hoarse, breathy, or normal. As far as the feeding is concerned, we need to see whether feeding is difficult, or is it drooling, or is it normal as far as the swallowing mechanism is concerned. And as far as the site is concerned, very important that we try to guess as to which site the problem is. So it extends right from the nose, oropharynx, supraglottic, glottic, subglottic, and tracheal areas. The airway starts from the nose, goes all the way to the trachea, and was pointed out in the previous slide, you need to have a look at the digestive system also. And as far as the overall appearance of the child, when you see the child in your clinic, you need to look for retractions, whether there are retractions or no retractions, if the chest is normal, are there any suprasternal, intercostal, substernal, or subcostal retractions. That also gives you an idea of the severity of the problem. Now, you need a multidisciplinary team approach to take care of the pediatric airway. You need a neonatologist, you need the pediatric ENT specialist, the anesthetist, the pediatric gastroenterologist, the pediatric pulmonologist, the pediatric surgeon, speech and swallowing therapist, one of the most valuable people in the group, and of course, various support staff, especially trained nurses, and sometimes we have more than one anesthetist in the room because things can really go bad. What are the various definitions and anatomic divisions based on the anatomic divisions? Now, stertor or snoring usually comes from the nasal or the pharyngeal airway. Stridor is usually an upper airway issue that is starting off from the supraglottis, glottis, subglottis, and the trachea. And wheezing is from the lower airway. Now, it's very important to time the respiratory sound, and that gives you an idea of the probable site of obstruction. So we have the pharynx and epiglottis in the upper area. where inspiratory stridor is the common symptom. If there is biphasic stridor, glottis, subglottis, cervical trachea, all these things could be involved. Any of these sites could be involved. As far as the thoracic trachea and bronchi is concerned, usually it is an expiratory stridor. Now let's look at the causes of pediatric stridor, but the laryngeal subsite. So you have supraglottis, you have glottis, you have subglottis. Now here in the supraglottis, the commonest problem that we see is laryngomalacia, one of the commonest causes of stridor. Almost in 70% of neonatal stridor is because of laryngomalacia. You could have a laryngocele, you could have laryngeal stenosis, you could have vascular malformations, or a neck mass. In the glottis, you have vocal cord paralysis, intubation injury, laryngeal cleft, glottic web, stenosis, laryngeal trauma or fracture. Then in the subglottis, you can have croup, you have intubation, granulation or edema, acquired stenosis, hemangioma, cysts, congenital cricoid malformation, or a foreign body. Now, one caveat as far as croup is concerned, if any child is getting multiple attacks of croup before the age of 2, then please look for a type 1 subglottic stenosis, which becomes worse with the infection. Now, airway obstruction could be partial or it could be complete. If it is partial, it could have started off abruptly or it could have occurred gradually. And as far as complete obstruction is concerned, of course, it could lead to cardiopulmonary arrest and standard resuscitation guidelines have to be used. Now, how do we evaluate the child? History is very important, like in many other clinical conditions. Initiations of symptoms. When did it start? And in the subsequent slide, you will know why that is important. Duration of the symptoms, whether it's continuous or is it episodic, is important. And is the symptom worsening? Is it steady or is it improved? Then, is there weight loss or failure to thrive? Associated feeding difficulties, is there or not? Whether there's a history of intubation, whether there's a history of prior surgeries, whether any neurological conditions are coexisting, whether it's part of another syndrome and you may have to do some genetic study. Now, this is very important. At what stage or what age of onset is very important. If the problem is at birth, the conditions which are there right from birth are choanal vocal cord palsy, laryngeal web, stenosis, vascular ring, or cystic lesion. If the child is fine initially and after a few weeks you have laryngomalacia could manifest itself, tracheomalacia could manifest itself, and subglottic stenosis along with that is also subglottic hemangioma. If the child is coming at age 1 to 4 years, it could be croup, it could be epiglottitis, or it could be foreign body aspiration. However, infective, inflammatory, and anaphylactic causes can occur at any age. Now, how do you assess the breathing? You have to look at the effort of breathing, that is, the respiratory rate, any added sound, whether there is stridor or stertor or wheeze, whether the accessory muscles are brought into action, whether there is flaring of the nose. Then next is the efficacy of breathing, the chest expansion, the abdominal excursion, auscultation, whether increased, reduced, equal breath sounds are there, oxygen saturation, and the effect of respiratory failure on the heart rate, the skin color, and the mental status. All these things are important when you assess the breathing difficulty of the child. Now, if there is a difficult airway, now the range of interventions could be of various types. You could use what is called as non-invasive techniques like HFNC. You can use CPAP. So what we are trying to do is restore the airway, and it starts much before our expertise comes in. Neonatologists and pediatricians are very familiar with these non-invasive techniques these days, and we can prevent a tracheostomy, we can prevent an intubation by using these non-invasive techniques. So Like I was mentioned now, you could have non-invasive support, that is nasal prongs, HFNC, or invasive, which would be intubation and tracheostomy. Of course, we would try to avoid intubation and tracheostomy as much as possible. Now, you have to identify the problem in the difficult airway cases, and seeing is believing. So, you need to do a flexible fiber optic examination. It can be done right from the nose down to the trachea and beyond, and it can be done without the child sleeping, without child being given much sedation. Just roll the child so that the child is immobilized, and then you use the nasal flexible scope and have a look right from the nose downwards, and the child can just be given something in the mouth to suck, and transnasal you can go without sedation. It can be done in the OPD setting. Now, what are the indications for flexible fiber optic nasopharyngolaryngoscopy? One is severe stridor, progressive stridor, when the stridor is there and it's increasing, when stridor is associated with unusual features like cyanotic attacks, apneic attacks, dysphagia, aspiration, or failure to thrive. Now, if there's a radiological abnormality, again, fiber optic nasopharyngolaryngoscopy is very useful to identify the problem, and so that we can manage it better. Occasionally, we need to do the nasopharyngolaryngoscopy for stridor of the children where it's causing a lot of parental anxiety, to make sure that everything is fine. No, we have to restore the airway. That's our aim. It could be in the form of intubation. It could be in the form of tracheostomy. We could do what is called as an anterior cricoid split, where you just widen the subglottis. You could use an anterior cricoid split with a thyroid ala, which is used, thyroid ala cartilage, which is used as a distractor to augment the airway. You can have laryngotracheoplasty, where you can use costal cartilage, anterior graft, posterior graft, etc. You can have a partial or extended cricotracheal resection, and the new kid on the block, not actually new, but then slight tracheoplasty is extremely good for complete tracheal rings, and also in some cases of cervical tracheal stenosis. Now, endoscopic procedures are balloon dilatation, laser assisted stenosis surgery, sometimes coablation assisted surgery, laryngotracheal clefts are repaired, and then you have medical treatment. That is a real advancement, medical treatment for hemangiomas, where we give propranolol and we can avoid surgery. Exit procedures, extrapartum, intrapartum therapy, extrauterine intrapartum therapy, where the problem is anticipated prenatally, and a partial cesarean section is done, and the child's airway is restored. And of course, robotic surgery requires a little more refinement to use in these small children. So it's important to know what the problem is, because many of these problems are self-resolving. You put your hands in your pockets and the child gets better over a period of time. There are some conditions which are medically treatable. There's some conditions which require minimal intervention, surgery, no more than that. Then you could have simple open surgery, or you could have complex open surgery. So it's important to get the right fit by proper history taking, proper diagnosis, the basis of which is, again, I'm repeating, is flexible fiber optic nasopharyngolaryngoscopy. Now let's look for the cause. On the far left, you have choanal atresia. It is one in about 10,000 or 8,000 births. And then you can have choanal atresia, which is membranous, which is mixed, or it could be bony, it could be unilateral, it could be bilateral. And usually most of the urgent interventions are done for bilateral bony atresias. The various ways, and now the accepted treatment is a transnasal endoscopic approach. There are people who raise flaps, but it's maybe difficult in a child who's weighing less than 2.5 kg. You may not have enough space. All said and done, choanal atresia can be addressed by opening up the choana. Then you have the nasopharyngeal mass, which can obstruct the airway, and it's of various types, and you have to go and excise it. And here you find that structure there. Then you can also have sublingual mucocele. This child was delivered through a exit procedure because it was identified prenatally, and a simple macroglossia can give rise to obstruction too. Then you have a vallicular cyst, and this is something that is very easily taken care of. You can use marsupialize this area with a laser, with a coablator, with cold cut instruments. It doesn't really matter. But in this area, sometimes you can have a thyroglossal cyst also to make sure that the thyroid gland is functioning thyroid gland is there before you decide to do anything else. Then laryngomalacia, of course, is the commonest cause of neonatal stridor, and many of you might have seen that. So we need to decide which are the cases which require surgery, which are the children who do not require surgery and just observation, and what type of surgery has to be done, which we'll discuss later. Now, this bifid epiglottis is part of the Pallister-Hall syndrome, and so this is another congenital anomaly, relatively rare. Then we have a laryngeal hamartoma blocking there. So these are the multiple lesions which can cause airway obstruction. Again, seeing is believing, and once you see that, you can have your treatment plan in place. Now, extremely rare conditions like non-canalization of the larynx here, the vocal cords are here, but there is no opening there. Then we have the laryngeal web. Actually, this is the whole spectrum disease, where you can have a web here, or you can have a much deeper web leading to non-canalization. Then you have vocal cord palsies. Then you have the laryngeal cleft, where it's obligatory after you can suspect a laryngeal web based on the history, but you need to do a rigid laryngoscopy, telescopic laryngoscopy, put this thing, what's it called, L-shaped distract and see, and find out whether it's grade 1, grade 2, grade 3, or grade 4. And then, of course, here is the hemangioma, which you used to operate, sometimes open, sometimes endoscopic, sometimes use laser. But right now we have the happy solution of using propranolol, 1 milligram per kilogram body weight increased to 2 milligram per kilogram body weight, and then use for maybe 6 months or 3 months, and you can use short courses of steroids in between, and extremely good. I mean, it's a wonderful treatment. This is a real advancement, medical advancement. And of course, you have subglottic stenosis. It's classified according to Cotton's Meyer classification, and you need to find out how much of the airway is obstructed, and you have grade 1, 2, 3, 4. And apart from that, Monier and has modified this, and it takes it into account whether the child has got any comorbidities, and then whether the child has got any impairment of the movement of the vocal cords. All these are very important in assessing the outcome. Trichomalacia, of course, is another condition where exotic surgeries are there, but then many of the cases do settle down over a period of time. And here you see that the lumen is almost crescentic every time the child is breathing, so there's a collapse here. And finally, the mother of all problems is the complete tracheal rings, and tracheal stenosis at this level with complete tracheal rings. You need to have a lot of expertise in this area, sometimes work with the cardiothoracic surgeon, and then do a slight tracheoplasty. But what is important is that we have to be prepared. Airway case trolley arrangement is very important. If you're not prepared for the multiple instrumentation that you require at short notice, you'll be in trouble. Be over prepared rather than under prepared. All the scopes here, you can see the Benjamin Lindholm scope. This is the Havas Benjamin light clip, which is very, very useful. Towel clips, and then various sickle knives, suction tips with an olive tip in the extreme end, so that we don't damage the cord every time we suck. And then you have the other instruments all of you are familiar with the tracheoscope, the nasal endoscopes 2.7 and 4 millimeter, and 0 and 45 also. Now, the airway set for tracheostomy procedure is a special set. You need to keep it so that you can access it at any time at 3 o'clock in the morning, 2 o'clock in the evening, and there is no point in searching for instruments later. And The airway set for a bronchoscopy procedure is completely different. We need the right type of forceps to grasp there, we optical forceps here, and then various sizes of bronchoscopes to be kept. This is the bung here. This is the lens here when the patient initially anesthetized, then we remove this and we'll show you a video on those things. This is an extremely useful scope. Actually, it's a valliculoscope. You put it in the vallicula and have a beautiful view of the infant larynx or the neonatal larynx. This is the light carrier. I told you about the Havas Benjamin light carrier. This is the one. And we have these special instruments. This is the distractor or L-shaped instrument, which is used for laryngeal cleft assessment. And then this is the suction tip. And this is, of course, the chest piece. Now, you need to have a checklist for airway cases. You have all these things, check out bowl with normal saline, bowl with Savlon, lignocaine jelly, etc., etc. And the airway instruments also, we go and we tick mark all these things like a pilot before he takes off in an aircraft. It's an Air Force, old Air Force trick that you have a checklist, tick mark everything before starting that, including recording system, which is very, very important, monitor, microscope, microdebrider, etc. And instrumentation, be ready for the worst. Availability, accessibility, affordability, surgeon skill, these are all important. You have the cold instruments, you have the CO2 laser, you have the microdebrider, you have the airway balloon, you have the coablation. If you have all these things, you're wonderfully equipped. Now, you can use, as far as, for example, let's take the example of laryngomalacia. The aryepiglottic fold trimming can be done with forceps, it can be and scissors or laser coblation. It's not the tool which is important. They all give equally good results. It's the skill that is important, and also the anesthetic support and post-operative support. Here we are using the cold cut instruments to remove the redundant mucosa at this level. And here the laser is being used, and you can see the laser is used to give these cuts. And here we use the coablator for snipping the aryepiglottic folds, and this is coablator being used for the redundant tissue at the level of the arytenoids. Now let's compare what if we do. This is the way we were doing the surgery earlier with um, uh, you can see that that's a laser being used here. You can see that, and it's a fiber laser CO2 duo, which has been delivered like this. And you can see how easily the tissue is separating, and you have to remove the charring if it occurs. If you don't create a charring, no need, but then if it's very superficial, it just becomes clean and nice. So you can see that here. And let's try whether a cold cut gives the equal results. So we used a cold cut on one side, and we used a laser on one side, a CO2 laser. So you can see the cold cut gives almost similar kind of results, not too much of bleeding. So you don't have to tell the patient, I don't have a laser, go somewhere else. You can use cold cut also. If you have a laser, by all means, you can use that. And you can see the end results on the left side. You can see we've achieved almost the same on this side without much of bleeding. All right. So we go next to the new kid on the block. That is, we also use the coablator, and it's a nice tool to use. But whenever you use any of these heat instruments, including laser and coablator, be very, very careful. And remember, we are not having any tube here. We get tubeless anesthesia from a fantastic anesthetist. So going back to some tricks in pediatric airway surgeries. Now, pediatric tracheostomy, all of us should know. Probably you have a lecture the next day. I'll just quickly go through certain important tips and tricks. Here is position is very important. Next, the incision. Then you have the dissection. Then you have the stay sutures, which have to be put. The tracheal incision, how you do it is important. Insertion of the tube. And then here we're inserting the tube and sutured and tried. Now let's quickly have a look at this very short video, which is self-explanatory. And you can see how we are immobilizing the child, because many times the trachea can move from one side to the other. It is soft and you might lose control. And so it's very important to uh, have a good extension so that you can have the trachea as close to the skin as possible. And soon after that, let's see, yeah, so that is the important tip that I wanted to give you. So initial step would be marking and infiltration. This is very important. And subsequent to that, you can, that's the marking going on, very important, cricoid level and the sub suprasternal notch, and somewhere in between the midpoint is the place that you give the marking, and then you do the infiltration. And you can see you raise that area. I think this video is quite self-explanatory. And that's the incision given with the 15 blade. And once you do that, you have um, the fat, excessive fat, which has to be removed in children, so that you can look at the surface of the trachea, and you can see that whatever fat is removed, so that, yeah, and control the bleeding. And now you separate the strap muscles. Once you separate the strap muscles, you use the retractors on either side, and after that you're almost on the tracheal wall. Make sure as to which tracheal ring you're going through. We avoid the first tracheal ring, as you all know already. You can see um, cricoid there, sorry, the trachea there, and then you take the tracheostomy tube, use a little stain there, and touch the area so that you approximately know how much of space you need. So this is a good, so that you can do the right amount. But before doing the incision, what you need to do is take these stay sutures. They're very useful, and to make sure that your trachea can be pulled up with that and it doesn't sink lower down. And here we're giving the incision. So incision could be vertical or it could be horizontal. Various people have outlined the advantages of the vertical, and I don't think it really matters over a period of time. We know maturation sutures are very important, so that even if the tracheostomy tube slips out, the opening is there, and the nurse or anybody, bystander, can insert the tracheostomy tube. So we are doing maturation sutures in all the cases, and the circuit is connected. And soon after the circuit is connected, what we are doing now is to also to check the oxygenation and confirm and look for the EtCO2, and then inflate the cuff, and the job is done. That's it. And then you suture, skin sutures you put on either side, and then so we are almost done. So the tracheostomy patient card is very important, which gives all the information of how you did it. You can see this was designed by our fellow, Dr. Deepa, where everything is there, and post-operative care also, how to change the tube, regular cleaning, airway protection, call urgently, block granulation. The entire thing is here, so the nursing staff who is taking care, or the junior doctor who's taking care, knows exactly what was done, and you also sometimes tend to forget what you did, so it's very, very important. And then here, of course, we've got a checklist for tracheostomized children prior to discharge. And now the next step we are going to do is the pediatric bronchoscopy. It's difficult to manage because of the narrow airway, difficult instrumentation, and we have a shared airway, and subglottic edema can occur very easily in children below 1 year. Now, this is a child with a foreign body aspiration. You could be seeing the child in the initial phase of aspiration, where the child comes with coughing and choking. If it's an asymptomatic phase, there's relaxation of the reflexes, and there's reduced, absent, or persistent symptoms. And the child could come to you during the complication phase with secondary effect of airway obstruction, which could be erosion, it could be pneumonia, it could be atelectasis or abscess. What are the preoperative concerns? While waiting, you need to oxygenate the child. You need to monitor the child, probably give steroids, adrenaline nebulization where appropriate, and the consent for complete removal, partial removal, dislodgement of foreign body, repeat procedure possibility, tracheostomy, and complications in intensive care, and even possibility of death has to be explained to the attenders before you undertake the procedure. Anesthesia, it's a shared airway. It could be night or daytime, so you need to have an experienced anesthesiologist. Local anesthetic spray prevents spasm. Ventilation via bronchoscope or jet ventilation is done. You have to avoid pre-op sedation in patients with stridor, and spontaneous ventilation is preferred. Sometimes it's necessary to introduce the endotracheal tube and oxygenate pre-oxygenation before doing the bronchoscopy. Of course, avoid too much positive pressure ventilation. It could dislodge the foreign body or give an burst in emphysematous bulla. And the instruments, of course, the suction tip is here. You have the bronchoscope. You have the optical grasping forceps. This is the real revolution which has made it easy. You can keep ventilating the child as you're using the optical forceps, and under vision you can remove the foreign body. This is the suction rubber guide, rubber bung, and this is the forceps, and different type of forceps are available. And how do you assemble the instrument? Very important. This is the most important part. So here we have the attach the light prism to the bronchoscope. As you're seeing in this, it goes with a click sound. And then once that is secure, yeah, make sure everything is fine. Then you take the suction guide to the suction port. And subsequent to that, what you need to do is to select the optical grasping forceps, and you find whether it's working properly, and insert the Hopkins rod into the optical forceps, and then screw it shut, and the light assembly which comes out should be vertical. That means it is locked. Align vertically and lock the assembly. Once you do that, you take the suction, keep it ready, and then you have the light attached, light cable is attached to the light prism, and you keep all the instruments ready, make sure everything is working and in order before you start the case. Apply lignocaine gel and insert the assembly into the bronchoscope, and then you see whether there's a port for anesthesia circuit, and then see whether the forceps can be opened and closed. So that is very important to check. And after that, the position of the child should be supine, cervical spine flexed, and head extended, so that you can have a direct look at the airway. And through the right side of the mouth, you insert the bronchoscope, identify the glottis, and progress the scope. Rotate the bevel to one side at the level of the glottis, and progress until the beak after straightening it through the vertical axis of the glottis. Gently twist and advance past the larynx. So that is the way you do it, so that it's atraumatic. And here we have the prior arrangements and assembly of the instruments we showed you. And this is how you do the bronchoscopy. Turn the head position to progress the scope in the bronchus, or you can turn the patient, or you can turn yourself, and use suction to remove the excess secretion. And the suction tip, preferably when you insert it past the vocal cords, you can keep it closed and open it later. Insert the optical forceps, grasp the foreign body, and get it out. That's the way you need to do that. And combined withdrawal of the whole assembly may be required. Yes, withdraw the forceps and the bronchoscope together, and that's the way to do it. Now, the prognosis depends on the type of foreign body, location in the airway, length of time between aspiration event and diagnosis, and host reaction to the foreign body. And the cause of death could be sudden asphyxia, respiratory failure due to central airway obstruction, bradycardia, undiagnosed tension pneumothorax. So hang around after removing the foreign body, stay for a while, and don't declare victory after removing it. You could land up with some tension pneumothorax or some other problem. So be around and spray the cords as soon as you remove the foreign body, and that sometimes the children may have to be intubated following that for a while. So we go to the subglottic stenosis. It could be acquired or congenital. It could be membranous or cartilaginous. The third most common congenital airway problem after laryngomalacia and cord paralysis. And you have to select the treatment modality. You can have repeated failure of extubation in a neonate with isolated subglottic stenosis. A child who's got weight is more than 1,500 grams, no active respiratory or cardiac comorbidities. One of the things that you can consider is what's called as the anterior cricoid split to widen the subglottis. And that's the anterior cricoid split we are showing. And this is the schematic diagram where you do the split and then put a thyroid ala cartilage here, and there's a short video which I'll show you, which is self-explanatory, and later. And what is the treatment modality that you will choose in these cases? If it is early soft stenosis, granulation tissue, primary edema without fibrosis, then if this limited isolated pathology, grade 1 stenosis or seal flipper granulation, which go up and down with every respiratory cycle, then you can do endoscopic treatment of granulations, cold steel rather than CO2 laser, balloon dilatation, mitomycin C, or endoscopic cricoid split. And patients not suitable for surgical intervention because of oxygen requirements, neurological abnormalities, craniofacial abnormalities, you can try these endoscopic interventions. So this is the balloon dilatation, and this is before dilatation and post dilatation. And sometimes you can give incisions, or you can use the laser and make incisions, or cold cut and then use the balloon dilatation. And nowadays we use balloon as an adjunct post-operatively, also during the surgery after doing certain the split, etc. You can use the balloon dilatation to augment the area. Now, for symptomatic laryngotracheal stenosis, grade 3, 2, and 3, if the patient weight is more than 2 kilograms, and you have oxygen requirement is less than 30, you can do a laryngotracheal reconstruction with cartilage augmentation. And now we'll just show you a video of the thyroid anterior cricoid split. Now, this is what we do. This is an extremely good operation because it helps in avoiding pediatric neonatal tracheostomy, useful for congenital subglottic stenosis, as long as there's not too much of deformity of the cricoid. So you just go there, and as shown in this picture, you're doing the midline exposure, and after doing the exposure, get the muscles out of the way, and after that you're putting these stay sutures on either side, and then mark the area for the harvest of the thyroid ala, as you can see, and take out the thyroid ala, and then you make the anterior cricoid split, which you're doing now. And once that is done, you expose that area, distract it, and then you measure the graft. This is important to have the right size so that the cartilage doesn't go inside and abut the lumen. And once you do that, the sutures are done to the ala in this manner, about 2 or 3 sutures. And once that is done, you can see that this thyroid ala is being kind of a picturesque word, that is, you're parachuting it into the gap there and stabilizing the cartilage there. And so by using the thyroid ala as a distractor, the results of this surgery has improved tremendously. So that's the anterior cricoid split with thyroid ala augmentation. And grade 3 or grade 4 stenosis, you can do a cricotracheal resection and long segment stenosis extending into the trachea, or used as a salvage after failed laryngotracheal reconstruction. So non-canalization of larynx is a very important clinical oddity. You can, for the sake of time, I'll run both these videos at the same time. See, here we have a child with this non-canalization, but there's a small opening here which allowed the child to breathe till the tracheostomy was done. In this particular case, there's absolutely no opening. It's total non-canalization, and these cases are best taken care of by the exit procedure. In the right side, the child was breathing till the tracheostomy was done due to a tracheoesophageal fistula, which kept the child alive. And the laryngeal webs, of course, failure of recanalization of the larynx, and various grades are there. And basically, we need to, if it's very deep, you need to do anterior grafting has to be done. And algorithm for the management of laryngeal webs are like this: anterior thin web without glottic extension, breathing and voice is normal, you do nothing. If it is abnormal, then you do laser and you can use mitomycin. If an anterior thick web without subglottic extension, you need to split the web and externally or endoscopically. Anterior web with subglottic extension is a different ball game. You have to do a laryngotracheoplasty with an anterior cartilage graft. And if subglottic hemangioma, I told you, you may have to do a tracheostomy, but it's best avoided. And the laser ablation can be done with CO2 or KTP, but all that has been superseded by the propranolol, which works like magic. And very, very rarely you may have to do an open excision. So the posterior laryngeal cleft is another clinical oddity, as you can see. And you can see this video. You take this distractor, go down. It's very important to use rigid instruments to grade these conditions. Otherwise, a flexible fiber optic laryngoscopy alone will not be of use. You must have seen in most of the airway lesions that we've talked today, imaging is not a primary investigation. It's of use basically when there are complex abnormalities or when you're suspecting an external compression. And to conclude, pediatric bronchoscopy is an art. A difficult airway, please call for help. Seeing is believing. Identify the problem early. It needs practice and understanding of instrument handling in small tracheobronchial airway. Airway adjuncts, develop the skill to use appropriately. And as far as a small breach in mucosa or airway can lead to a life-threatening complications, so be very careful and gentle with your instruments. Proper training of instrument insertion and constant patient monitoring very crucial to prevent such events. At least 4 hours post-operative observation to look for delayed surgical complications. Teamwork of anesthesiologists, otolaryngologists, pediatric pulmonologists, pediatric intensive is very important for better outcome of such cases. And the most important thing that you have to know and make your pediatricians or neonatologists remember is that all stridor is not laryngomalacia. There could be something else, because many a time neonatal stridor, the patients are reassured that it'll settle down soon, not to worry. No, they have to be observed. You have to have a watchful eye on them and intervene if and when required with the appropriate surgical or medical modality. Now, our aim is to restore airway and breathing. Here's a child. We've taken permission to show this video to you. And what we need is restore the airway, breathing, voice, and swallowing. And you can see here that we have luckily So we have restored the airway, we've given the child a voice, and child is able to feed. And this was a congenital subglottic stenosis where we've achieved all three. That should be our aim. Finally, I need to thank my pediatrician neonatologist, anesthesiologist colleagues of Manipal Hospital, Bangalore. And of course, thank you to my little patients who are hopefully breathing easier. Without our patients, we would not have been able to gain the experience we've done in the last 20 years. We also have fellowship programs and we have training programs and updates on various airway procedures where the best surgeons and faculty from Cincinnati, from Perth, from Lausanne, Texas come and help us train other Indian doctors. If you're interested, please keep in touch with us. We'll be very happy to have you there. Thank you so much for your attention.
Thank you, sir, for that illuminating talk. We have a few questions for you from the delegates, sir. The first one being the basic difference between stridor and wheeze.
Stridor and wheeze. Okay.
Yes, sir.
Wheeze, the origin of wheeze is usually in the chest. So it's an expiratory sound. Okay. respiratory sound, which comes from the lungs, whereas the stridor is something which comes from somewhere in between. Stertor comes from the nose. It's akin to nose and the upper oropharynx area. That's akin to snoring. And stridor has got a very distinct sound. It could be inspiratory or expiratory, as we have mentioned. And wheeze is best confirmed with a stethoscope. And I'm sure over a period of time, clinically, we would be able to differentiate between these two very easily.
Okay. Thank you, sir. So you did mention that during laryngotracheal reconstruction, you used the thyroid ala graft to reconstruct the deficit. So the question is, which part of the thyroid ala do you specifically prefer to?
The upper part of the thyroid ala, it's a fairly simple procedure. If you know how to do a septoplasty and raise the perichondrium, you'll be able to do this. And basically, originally, this surgery started off with just an anterior cricoid split, and the child was kept intubated 7 to 10 days. Now, there was a possibility it could narrow down. The success rate was around 60%, but with the distractor like thyroid ala, which is easily available locally, you just need to go a few centimeters here and you find the thyroid ala. It is used as a distractor, and you can remove the endotracheal tube, which is used as a stent post-surgery much earlier, between 3 to 5 days. So that is the advantage.
Okay, thank you, sir. One last question, sir. How do you decide when you want to intubate versus when you want to do a tracheostomy in a child, in a pediatric case?
So basically, all of you must have heard about the Mausio's dictum. It says, when you think of tracheostomy, just do it. That's undergone a little bit of a change thanks to non-invasive ventilation techniques, which have developed in the recent past, and CPAP. You can avoid tracheostomy for as long as possible. As you know, tracheostomy is a huge burden, not only while in the hospital, but also later for the parents to manage this. So it's very difficult to manage these cases, the commitment of the parents, the costs issues, the mental issues, etc., etc. So thankfully, as much as possible, one can try to do non-invasive ventilation. If it doesn't happen, then of course you have to resort to tracheostomy. But in some cases, you know that you have to do a tracheostomy. You have to do it immediately, think of it and do it immediately. That is very important.
Okay. Thank you, sir.
One more thing is, I have given you an alternative of avoiding neonatal tracheostomies by doing the anterior cricoid split in congenital subglottic stenosis.
Okay. Thank you, sir. Thanks for taking time off your busy schedule to be with us this morning.
Thank you very much for this opportunity, and thank the organizers and you for moderating the session. Thank you so much. Take care.
Delegates are now requested to move to Hall A for the rest of the scientific session. The PG award papers will be happening in Hall B post 1 p.m. Good afternoon, dear delegates. Here in Hall B, we now have presentations for the PG award paper and the SLP award paper categories. So please sit back and enjoy yourself.
Good morning, judges and delegates. Myself, Dr. Advari Gute. I'll present my topic for today, subglottic stenosis, balloon dilatation or experience. Subglottic stenosis is a narrowing of the airway extending from the inferior margins of vocal folds to the lower border of cricoid cartilage. It can be congenital or acquired. It is a life-threatening airway emergency, often requiring long-term or permanent tracheostomy. 90% of all cases result from prolonged endotracheal intubation. Pressure and motion of tube against cartilage framework may cause ischemia and necrosis. Duration of intubation is the most important factor. Risk of subglottic stenosis increases drastically after 3 to 4 days of endotracheal intubation, but can occur immediately also. Causes: systemic causes like gastric acid reflux, chronic illness, immunocompromised patients, anemia, poor perfusion, while chronic inflammatory disease like Wegener's granulomatosis, sarcoidosis, relapse in polychondritis leads to subglottic stenosis. Other causes are idiopathic, external trauma, tracheostomy, especially a high one, percutaneous tracheostomy, and chondroradiography. Presentation: patient presents with dyspnea on exertion or with rest, depending on the severity of stenosis. Stridor, hoarseness, brassica, recurrent pneumonitis, and cyanosis. Diagnosis is done on video laryngoscopy and radiological scans to know the extent of stenosis and involvement of tracheal rings. Coming to the management, open reconstruction surgeries require hospitalization in ICU and are associated with significant morbidity and even mortality. Endoscopic techniques are new, promising, comfortable, and patient-friendly. Management strategies have undergone constant refinement over the years. Hence, balloon dilatation coming up as an alternative treatment to open surgical techniques in selected cases. Controlled radial expansion, pulmonary balloon dilatation catheter ranging from diameter of 8 to 20 millimeters are used as standard balloon catheters. Advantages are: it avoids shearing trauma by rigid metallic dilators, exerts equal pressure at all stenoid segments, less morbidity and less mortality, and keeps option for open reconstruction surgeries open. Our aim of the study is to study etiology of subglottic stenosis, site of stenosis and grading, and efficacy and outcome of early intervention of balloon dilatation in patients with subglottic stenosis. Ours is a prospective study carried out in ENT department at Tertiary Care Center in Central India with a sample size of 7 and study period of 24 months and ongoing. Patients with post-intubation and post-laryngotracheal open surgery diagnosed with soft subglottic stenosis were included in the study, while patients with other diseases causing airway obstruction and malignancy were excluded. Detailed data was obtained with regards to the age, etiology, mode of presentation, indication for tracheostomy or intubation, details of intubation, previous surgery, and details of decannulation. All the patients underwent direct video laryngoscopic examination, and following points were noted: vocal cord mobility, posterior glottis, anatomic location of stenosis, length of stenosis, nature of stenosis, and grading. This is the balloon dilatation assembly. We use Tycheck's balloon, which is a peripheral vascular balloon, double length Terumo wire with indeflator. It is 4 cm long and 18 mm in diameter. Peripheral vascular balloons were used due to economic constraints in government setup in a tertiary care center. Balloon dilatation was performed with the help of cardiology team. Time of inflation was 2 to 3 minutes with a pressure of 6 to 8 cm and was done twice in one sitting. Topical substances such as steroids and mitomycin C were used to optimize endoscopic treatment. Mitomycin, an antibiotic, has anti-fibrinogenic and anti-neoplastic activities that block fibroblast proliferation and scar formation. Coming to the results, pediatric age group of less than 10 years constituted maximum number of sample size, with 3 patients contributing to 42.85%. Youngest patient was of 4 years. Majority of the patients were male, corresponding to 71.42% of total sample size, with a male to female ratio of 2.5:1. Mode of presentation: 71.42% patients presented with stridor, while 14.28% each developed stridor with exertion and repeated desaturation. Indication for intubation: pneumonia and encephalitis constituted the most prominent factors, while COVID, Guillain-Barré syndrome, and OP compound poisoning were all the predisposing factors that led to respiratory failure and eventually intubation. Details of intubation period: 5 patients were intubated for a prolonged period of 10 to 20 days, constituting 71.42% of total sample size, which resulted in subglottic stenosis. all the 7 patients had to undergo emergency tracheostomy. Now, details of the previous surgery. Study comprises of 7 patients of subaortic stenosis. 5 patients were of post-open reconstructive surgery, while 2 patients were of post-intubation subaortic stenosis. Grading of stenosis was initially done by video laryngoscopy. Most patients had grade 4 stenosis according to Cotton-Wear classification, constituting approximately 42.86% of total sample size. Decannulation was successful in 3 patients. 2 patients of post-open reconstructive surgery are still under follow-up with 3 sittings of balloon dilatation done with suboptimal lumen improvement seen, while 2 patients of post-intubation subaortic stenosis are still under follow-up with 4 sittings of balloon dilatation done with marked lumen improvement seen. These patients are waiting further sittings. Coming to the discussion, at subglottic level, healing occurs with scarring resulting in subglottic stenosis. Long-term or permanent tracheostomy hampers social life with vocational impact. Until the 1980s, endoscopic metallic dilatations were most often used to treat subglottic stenosis, but they cause shearing injury to the mucosa. Surgical reconstruction popularized after the publication of Fearon and Cotton. With the advent of high-pressure airway balloons, balloon dilatation has been increasingly used for the treatment of acquired subglottic stenosis. Balloon dilatation of the airway provides an opportunity to apply radial force to subglottic narrowing and thereby prevent shearing forces created by rigid dilator. Conservative endoscopic dilatations give promising results in iatrogenic cases of stenosis and may be sufficient for grade 1, grade 2, and even in grade 3 stenosis and in those with post-op recurrences. Usually, 3 to 6 endoscopic balloon dilatation procedures are recommended. The success rate of endoscopic treatment varies, ranging from 60% to 70% for balloon dilatations. An open reconstructive procedure is considered in those who show no improvement with conservative endoscopic management and those with grade 4 stenosis, if needed. Coming to the conclusion, intubation or tracheostomy is an important cause of subglottic stenosis. Balloon dilatation is less invasive, less morbid, effective, and avoids major surgery. Balloon dilatation can be performed in failure of post-open reconstructive surgeries and recurrences with suboptimal lumen. Balloon dilatation optimizes results of open reconstructive surgeries. These are my references. I thank you for giving me this opportunity to present the case. Thank you.
Good morning, everyone. I'm Dr. Arushi Bhardwaj, and I'm presenting a paper in the category of PG category. The topic of my paper is clinical manifestations and treatment outcomes of laryngopharyngeal reflux on larynx and the symptom-sign correlation. Laryngopharyngeal reflux is the laryngeal manifestation of gastroesophageal reflux. It is caused by the backflow of gastric contents into the upper aerodigestive tract. It is one form of the extraesophageal reflux, and its events occur in the upright rather than in the supine position. The larynx is lined in parts by areas of very delicate squamous epithelium and elsewhere by respiratory epithelium, which is far less resilient than the esophageal mucosa. So the gastric reflux often contains acid content, but in addition to hydrochloric acid, it also contains enzymes, notably pepsin, food residues, bile acids, and bacteria. The reflux symptom index, that is RSI, is most widely used for the analysis of symptomatic effects of LPR. Although it is fairly sensitive, but it has limited specificity. The reflux finding score, that is the RFS, is used as an indicator for analysis of signs of LPR on larynx. Scoring of the signs are done. So out of the potential scores of 26, Bilavsky et al. Considered a score of more than 7 to indicate LPR. Most patients with LPR are diagnosed on clinical basis, including the history taking an examination with a flexible rigid laryngeal endoscope. Possible treatment for LPR includes dietary and lifestyle measures, medical treatment, and the anti-reflux surgeries. The aim is to evaluate various clinical signs and symptoms of laryngopharyngeal reflux on larynx along with treatment outcome and to establish a symptom sign correlation. So we took, it is a prospective study of 50 patients with symptoms and signs of LPR, which was conducted from January 2021 to September 2021. The cases were enrolled for the first 3 months, and the follow-up was done for 6 months. All the patients were evaluated with 70-degree Hopkins rigid laryngoscope. The inclusion criteria being the patients with symptoms suggestive of LPR and the patients with telelaryngoscopic signs suggestive of LPR. The exclusion criteria included patients below the age of 18 years and above the age of 60 years, patients whose video stroboscopic assessment could not be done, and the patient who are unwilling to participate in the study. So the reflux symptom index, that is the RSI score, was calculated based on the symptoms for all the patients in the study, and the telelaryngoscopic findings were noted and scored according to the RFS score. The patients in whom the RFS were less than 7 were labeled as others, while then patients with in whom the RFS scoring was more than 7 or 7 were labeled as LPR. So the treatment varied from dietary modifications to medical management, including proton pump inhibitors, which was given for a varying duration with a maximum of 6 months. Amongst proton pump inhibitors, pantoprazole 40 mg OD was prescribed to all the patients as it has better stomach acid suppression quality and it is cost effective, and due to its smaller size, so easy to consume. Dietary and lifestyle modifications included reduce consumption of spicy and oily food or tea and coffee and alcohol, and to stop smoking, avoid taking stress, a fixed sleep cycle. Post-treatment resolution of laryngeal signs and symptoms were observed, and the symptoms and signs of LPR were correlated. The pre and post-treatment signs and symptoms of the patients were compared based on the telelaryngoscopic findings and history given by the patients. So the symptoms were graded based on the reflux symptom index score, and the signs were graded based on the reflux finding score. In RSI, the lower grade was given, the minimum being 0 and highest being 45, and in the RFS, which is for sign, the lowest being 0 and highest being 26. So these are the RSI index, which include the symptoms, most commonly hoarseness, clearing of throat, excessive throat secretions, etc. And the scoring RFS, that is the science score, which includes subglottic edema, ventricular obliteration, vocal cord edema, posterior commissure hypertrophy, and so on. So we took total 50 patients in the study, out of which 31 were female and 19 were male, having the male is to female ratio of 1 is to 1.6. So the patients between the age of 20 to 40 were most commonly affected. Most common laryngeal symptoms according to the RSI scoring were sore throat in 40% patient, hoarseness of voice, 30% patients, followed by cough in 20% of the patients. The most common laryngeal signs based on the RFS scoring was posterior commissure hypertrophy in 40%, pseudosulcus in 30%, vocal cord edema in 20%, and granuloma in 10%. These are some pictures showing the posterior commissure hypertrophy, the edema of the vocal cord, and the common LPR changes. So all the 50 patients that were taken up for the study were treated with proton pump inhibitors and were asked to follow dietary changes and lifestyle modification for a period of 6 months. Out of these 50 patients, 21 which had RFS scoring of less than 7, that is complete resolution of the LPR symptoms after doing telelaryngoscopy, and were observed for after 3 weeks of treatment. The rest 29 patients with RFS scoring of more than 7 were taken. Out of these 29 patients, 19 had partial relief from symptoms after 3 weeks of treatment and were given treatment for another 3 weeks. The rest 10 patients were completely unresponsive to treatment. So these are the results pre and post treatment. Conclusion is that we compared the pre and post treatment symptoms and signs of all 50 patients based on the reflux symptom index and reflux finding score. While comparing the symptoms according to the RSI score, we observed that pre-treatment 36% of the patients were presented in the category of 0 to 15 in the RSI score, and post-treatment it came out to be 68%. 32% of the patients were presented in the category of 16 to 30 pre-treatment and 12% post-treatment. 32% of the patients were in the category of 31 to 45 pre-treatment and in the RSI score, which reduced to 20% post-treatment. On comparing the signs pre and post-treatment, we observed that 48% of the patients were in the category of 0-8 according to the RFS scoring, and which reduced to 18% post-treatment. 28% of the patients were in the category of 9 to 17 in the RFS scoring pre-treatment, which came out to be 34% post-treatment. And 24% of the patients were in the category of 18 to 26 in the RFS scoring pre-treatment, which came out to be 48% post-treatment. And so the above findings concludes that there is no correlation between the symptoms and signs, and the improvement in symptoms does not manifest any improvement in signs. Thank you.
Dr. Ashika Bagaria, second year postgraduate from Kempegowda Institute of Medical Sciences, presenting our study voice analysis in chronic renal failure patients under the guidance of Dr. Smita. Introduction. Chronic renal failure is a progressive loss of kidney function where the kidneys are unable to filter toxins and excess fluid from blood, ultimately resulting in the need of renal replacement therapy. Accumulation of dangerous levels of electrolytes, fluid, and toxins, and subsequent change in the biochemical parameters can affect various body systems. Respiratory and phonatory systems can get affected in chronic renal failure patients, especially on dialysis. These patients may present with voice dysfunction. The biomechanic harmony between airflow and laryngeal muscles can be determined using various acoustic parameters and voice handicap index. Aim and objectives. Aim, voice analysis in chronic renal failure patients. Objective, voice assessment of chronic renal failure patients based on voice handicap index scoring. Voice assessment based on acoustic parameters. Correlation between acoustic and renal function test of chronic renal failure patients. Inclusion criteria. Chronic renal failure patients aged between 20 to 60 years. Chronic renal failure patients on dialysis for more than 6 months. Previous exclusion criteria are previous history of voice disorders, laryngeal surgery, laryngeal trauma, patients who are highly morbid and bedridden. 25 chronic renal failure patients fulfilling the inclusion criteria underwent general, physical, systemic, and ENT examination, including laryngoscopic examination. Assessment of voice was done based on voice handicap index and acoustic parameters, including fundamental frequency, jitter, shimmer, harmonic to noise ratio, mean phonatory duration, and was compared with equal number of normal participants in control group. Correlation between serum creatinine and acoustic parameters were also studied. This is the voice handicap index scoring used for the study. Coming to the results, age, maximum number of patients in the study group were in the age group of 41 to 50 years. There were 16 male patients and 9 female patients in our study group. Patients underwent hemodialysis for 1 to 3 years, that is 68% of the patients. Voice handicap index score of 2 was the maximum in our study group. There was no statistical significance difference between the mean fundamental frequency values between the study and control. There was a statistical significance difference between the mean jitter, shimmer, harmonic to noise ratio, mean phonatory duration values between the study and control group. A positive correlation was found between the serum creat and acoustic parameters like fundamental frequency, jimmer, shimmer, and harmonic to noise ratio, and a negative correlation was found between the mean phonatory duration. A positive correlation was found between serum creat and voice handicap index. Discussion. Voice is produced by action of vocal cords and vocal tract consisting of oral, nasal, pharyngeal, laryngeal, and respiratory system, which depends on person's physical and mental well-being. Renal and pulmonary system work together to maintain the homeostasis of fluid, acid-base balance, and electrolyte levels. In chronic renal failure patients, there is gradual deterioration in the functioning of kidney, which in turn affects the functioning of respiratory system. Chronic renal failure and its associated conditions and medications can cause dysphonia owing to electrolyte imbalance, accumulation of toxins, immunosuppression, volume overload, anemia, impairment of muscle strength, and endurance. Voice handicap index is a reliable reflection of degree of disability caused by voice disorder. In this study, it is noted that 7 patients had voice handicap index score of 2 and a very weak correlation between the serum creat and voice handicap index scoring, which is statistically insignificant as contrary to the study done by Zaki. Various acoustic parameters helps in analyzing the voice quality, which depends on vibratory characteristics of vocal cord, influenced by its physical and transglottal airflow. Jitter is relatively average variability of pitch period, while shimmer is short-term variance in intensity of vocal signals, assessed by its amplitude, both of which are affected by aerodynamic influence in laryngeal mucosa. Dehydration of vocal fold and protein loss due to ultrafiltration during hemodialysis leads to stiffening of vocal fold and decrease the muscle mass and tension, which could lead to increase in the pitch of vocal fold. Vocal fold is edematous prior to hemodialysis due to fluid retention. Voice resonant not to glottal signal causes hoarseness of voice, which can be calculated by harmonic to noise ratio. In our study, mean difference of harmonic to noise ratio values between study and control group is 6.48, which is statistically significant, similar to the study done by UP et al. Chronic renal failure patients are known to show significant changes in biochemical parameters like urea, uric acid, and creatinine, which are increased, and hemoglobin bicarbonate and estimated glomerular filtration rate, which are decreased. This collectively could be responsible for increase in the fundamental frequency and shimmer and decrease in the harmonic to noise ratio. Anemia secondary to chronic renal failure causes generalized muscle weakness and fatigability, which can be responsible for a decreased phonatory control, thus decrease in the mean phonatory duration and increase in the shimmer. This may be contribution by the reduction in respiratory and glottal insufficiency. Serum creatine levels in blood is used to estimate the glomerular filtration rate, which helps in to determine the stage of the chronic renal failure. In our study, serum creatine levels have shown positive correlation with jitter, shimmer, and harmonic to noise ratio values, and negative correlation with mean phonatory duration in concordance by the study by Zaki et al. To conclude the study, voice analysis can be used as a non-invasive screening method to detect change in voice in chronic renal failure patients. These are the references used for the study. Thank you.
Good evening, respected judges and my teachers. Today I am going to present one paper on voice handicap in health worker during COVID pandemic. Since the declaration of COVID pandemic in 2020, the use of mask and PP for healthcare professional is a routine, and mask is a barrier for voice. So please listen to this young doctor.
When the sunlight strikes raindrops in the air, they act as a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors. When light strikes raindrops in the air, they act as a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors.
So there is a difficulty in speech and voice due to uninterrupted use of face mask in duty hours. So we put
When the
the objectives to evaluate the level of voice handicap of healthcare professionals in COVID era due to face mask use, specifically to compare any voice related discomfort of healthcare professionals in pre-COVID era and in COVID-19 era, and to compare any voice related discomfort amongst different categories of healthcare professionals. Now come to our study. Our study is a cross-sectional study including resident, consultant, ward sister in charge, ward nurses and health staffs, total 60 number of subjects. And our study was done in December 2021 in our tertiary care hospital. Healthcare professionals working in COVID ward wearing N95 mask and eye shield for a minimum period of 8 hours was included. Healthcare professionals from Department of ENT, healthcare professionals with previous voice disorder were excluded from our study. All the subjects were divided in 5 groups. Group A resident doctors, Group B consultant doctors, Group C ward sisters, Group D sister in charge, and Group E health staffs. Voice handicap index 10 was used for outcome measures. Then 10 questions related to voice handicap was used, and pre-COVID and post-COVID era responses were documented, and pre-COVID era responses were recorded as a recall method. Then student t-test was performed to assess if there any significant difference between pre-COVID VHI score and in COVID era. P-value less than 0.05 was taken to be statistically significant. Now come to our result. Male-female ratio was 37:23. The mean of pre-COVID era VHI score is 1.08 with a standard deviation of 1.59, and the mean of COVID era VHI score is 9.48 with a standard deviation of 5.93. In this diagram, the blue lines indicates the pre-COVID VHI score responses, and the saffron dots are the COVID era VHI 10 responses. So there is a significant or appreciable increase in the VHI score in COVID era. Then we compared the mean difference of VHI score in post-COVID response, where we found that the senior sister were the mostly affected, then the junior ward sister, then resident doctors, then consultant, then health staff. Claudia A. Haidar et al. In 2021, they have shown that healthcare workers in COVID-19 pandemic are at risk of voice disorder. Maria Lucia et al. In 2021, they have shown that wearing a mask increases the vocal effort, greater risk of developing functional dysphonia. Abdul Latif Hamdan et al. In 2021, they have shown that masking habits associated with high prevalence of vocal fatigue, effort, and abnormal VHI score among resident medical students and nurses. Our study goes in accordance with previous studies. So we can conclude that masking habit during COVID-19 pandemic is associated with a high prevalence of vocal fatigue and effort amongst healthcare professionals. Sister in charges in COVID ward were the most affected. There is statistically significant voice handicap in mask COVID era in comparison to unmasked pre-COVID period. The limitation of our study was that the pre-COVID VHI score was recorded in recall method, as there was no need of recording VHI 10 in health professionals in pre-COVID era. So more multicentric study is required in this aspect in Indian context. Thank you.
Hello, a very good morning to all of you. My name is Dr. Hanan Iqbal Khan, and I am a second year PG scholar in the Department of ENT and Head and Neck Surgery, GMC Srinagar. Today, I'm here to present a paper titled Aerodynamic Measurement, Maximum Phonation Time in Young Patients with Benign Vocal Fold Lesions and with Normal Voice. Let me give a brief introduction about the key ideas in the study. Clinicians have different tools to assess vocal function. Aerodynamic measures of voice include maximum phonation time in seconds. It will be referenced as MPT throughout this presentation. MPT is simple and easy to use as a clinical tool. It is the longest period during which a person can sustain phonation of a vowel sound, for example, E, A. 3 such readings are taken, and highest amongst them is taken as MPT for the patient. Impairment of vocal fold mucosa integrity due to lesions result in alteration of MPT. The reason behind this is the microwave movement of the vocal cord mucosa does not occur in harmony in these benign true vocal cord lesions like vocal cord polyp, nodule, or cyst. These lesions increases the mass in the free margin of the vocal cord, which affect the glottal closure and interfere in the maximum phonation time. Let us now discuss about the aims and objectives of the study. The study aims to provide data on MPT in adult male and female patients with benign vocal cord lesions and compare them with age and sex matched healthy volunteers. Materials and methods. The study was conducted in the Department of ENT, Head and Neck Surgery of Government Medical College, Srinagar, on 41 adult patients with benign vocal fold lesions and 41 healthy subjects matched for age and sex for a period of 2 years. Patients and controls were selected as per following inclusion and exclusion criteria. Inclusion criteria. Both male and female patients and controls in the age group of 20 to 42 years. Patients with benign lesions like nodule, cyst, and polyp in the true vocal cord, and controls with normal voice and without any lesion on cords. No chronic systemic disease in both patients and controls. Exclusion criteria. Patients of age less than 20 years or more than 42 years, patients with hyperkeratotic and malignant looking lesions, patients with vocal cord palsy or paralysis, patients with vocal cord sulci, patients with chronic laryngitis, patients with Rinke's edema. Clear instructions were given to patients and controls. They were asked to take a deep breath and phonate a steady state vowel sound for a maximum time possible in seconds. 3 such readings were taken, and the highest among them was considered as MPT for that particular subject. Data obtained was tabulated and statistically analyzed. We can start looking at some of the results of the study. In the present study, the mean MPT in seconds in male patient with vocal fold lesion was 14.4 with a standard deviation of 5.62, and in female was 10.8 with a standard deviation of 3.44. In control group, it was 18.15 second with a standard deviation of 5.88, and in female, it was 15.7 seconds with a standard deviation of 6.21. Mean difference between patients and controls in male and females was 3.8 and 4.9 respectively. P-value between two groups in male and female was 0.053 and 0.003 respectively. Discussion. Maximum phonation time is one of the aerodynamic measurement of voice production, which also includes vital capacity and phonation quotient. MPT is one of the most sensitive measures of these. It depends on many variables, including phonation volume, which itself varies with age, sex, and stature of an individual, mean airflow rate, comprehension of the task, and maximal effort. If the instructions and demonstrations are clear for the subjects, then 3 trials are sufficient to elicit a truly maximum duration for phonation. In the present study, there were a total of 41 patients, both male and female, in the age range of 20 to 42 years, out of which 19 were male patients within the age range of 24 to 42 years, with the mean age of 33.9 years, and 22 were female patients within the age range of 20 to 42, with mean age of 33.6. In control group, range of age in males was 22 to 42 with a mean age of 30 years, and in female it was 22 to 41 with mean age of 29.5 years. As we know, age causes change in MPT due to global change in anatomy and physiology in voice box and related organ system. The changes include decrease in power of respiratory muscle, less pulmonary elasticity, and sarcopenia in laryngeal muscle. Because of the above mentioned reasons, we have selected age-matched control group. As we have already discussed the MPT in seconds in male and female patients as well as in control, the results showed in both groups, male as well as in control, as shown in the table, MPT is higher in males as compared to females. This is due to increased vital capacity in males as compared to females. Similar findings were seen by Malson J. et al. In a study, as well as by Tasik PH et al. In a study. And similar other authors have seen this. I have quoted them in references. Presence of lesions like vocal nodule or vocal polyps has effect on MPT. How? First, it decreases the glottal resistance, increase airflow due to glottal gap, and reduce MPT. Second, it brings alteration in the firmness of glottis, which makes it necessary to redirect air pressure to start at and keep phonation. Therefore, decreased value of MPT are not only attributed to presence of lesion, but also to the lack of mnemophonic coordination. Other factors like epithelial hyperplasia, thickness of basal membrane, edema, and fibrosis all contribute to decreased value of MPT. These reasons explain finding of our study with mean decrease of 3.8 and 4.9 seconds in MPT for males and females respectively. Thus, we conclude MPT is a useful and simple test which gives a hint about the status of vocal cord. Vocal cord lesions decrease MPT in both sexes, even in young adults. MPT of males is higher compared to females due to increased vital capacity. These are some of the references, as you can see. Thank you for giving me the opportunity to present this study in front of all of you. Thank you.
Good morning. I'll be presenting a study on external laryngotracheal trauma, its presentation and management. External laryngotracheal injuries are rare and diverse. The extent of injury depends on the mechanism of injury. They are potentially life-threatening due to airway compromise, and they have morbidity associated with voice and airway complications. The injuries need to be evaluated as per the ATLS protocol. The priority is to establish and maintain a stable airway. Based on the mechanism of trauma, the injuries are classified as blunt injuries and penetrating injuries. The mode of injury can be accidental, suicidal, or homicidal. Schieffer-Furman classification of external laryngotracheal trauma is commonly used, with grade 1 injury having minimal edema and grade 5 injury having laryngotracheal separation. Injuries grade 3 onwards cause significant airway compromise and require a tracheostomy with open laryngeal exploration. An observational prospective study was carried out for a period of 2 years at a tertiary hospital in central India. Patients with external laryngotracheal trauma or its sequelae were included in the study. Patients with internal laryngotracheal trauma due to inhalational or iatrogenic injuries were excluded from the study. Total 24 patients were included in the study. 70% of patients presented to the tertiary care center within 12 hours of injury. Only 3 patients had a late presentation after 2 weeks. The mean age of patients presenting in our study was 29 years with a male preponderance with a male is to female ratio of 5:1. Half the patients had blunt trauma and half the patients had penetrating trauma. 7 patients had crush type of blunt injury. 5 patients had strangulation type of blunt injury. 75% of the blunt injuries were accidental and 25% were assault, while 91.6% of the penetrating injuries were suicidal. Patients presented with a neck wound, bleeding, difficulty breathing, and voice change. Other symptoms included difficulty while swallowing, neck bruising, and hemoptysis. 50% patients had associated concomitant injuries. Abdominal stab injury was seen with penetrating trauma, while chest trauma, head injury, fractured long bones, and cervical spine injury was associated with the blunt trauma. On assessment of voice at presentation, 45.8% of the patients were unable to phonate because of the injury, and 33.3% of patients had hoarseness of voice. Subcutaneous emphysema, the cardinal sign of external laryngotracheal trauma, was seen in 41.67% of patients. Other signs included dyspnea, stridor, ecchymosis, loss of laryngeal crepitus. Patients commonly presented with group 5, 4, and 3 injuries in our study, as per the Schieffer-Furman classification. Supraglottic edema, vocal fold hemorrhage, anterior glottic webbing, vocal cord paresis were the signs seen on laryngoscopy. Imaging was used to identify the airway breach, displaced thyroid cartilage fractures, laryngeal framework injuries in patients with no obvious external injury. The level of injury was noted intraoperatively and or radiologically. Isolated thyroid cartilage injury was most commonly seen with 1/3 of the patients. Isolated tracheal injury was seen in 4 patients. 67% of patients required an emergency tracheostomy under local anesthesia to secure the airway. Conservative management was done for 3 patients with minor injuries. Tracheostomy only was done for 20% of patients. Tracheostomy with surgical repair was done for 54% of patients, and primary repair after intubation was done for 3 patients with penetrating trauma. A total of 19 patients underwent tracheostomy, out of which 67% underwent emergency tracheostomy under local anesthesia, and for 3 patients, tracheostomy was done after intubation. Out of the patients who underwent tracheostomy, 7 patients could be decannulated on discharge. Complications seen included wound gaping, granulations at tracheostomy site, aspiration, secondary to glottic insufficiency, and death. Death was seen in 5 patients who had major injuries and had associated head and chest trauma. Our study was comparable to other similar studies. All the studies had a male preponderance. We had an equal proportion of blunt and penetrating injury. However, our study had more suicidal stab injuries compared to the other studies. We had more patients with major injuries compared to the other studies. To conclude, external laryngotracheal trauma was commonly seen in young males. Blunt injury was mostly accidental and had more complications and mortality. Penetrating injury was mostly suicidal and had better outcome with surgical repair. The priority is to establish and maintain a stable airway, which requires tracheostomy under local anesthesia. CT neck is an important investigation in evaluation of the laryngotracheal injuries, especially blunt trauma. The concurrent injuries must be evaluated. Group 1 and 2 injuries have a conservative line of management, and Group 3, 4, and 5 injuries require tracheostomy with open laryngotracheal repair. These are the references for my study. Thank you.
Good morning, all of you. I am Dr. Jiten Devendran, doing third year postgraduate in ENT, Kembagoda Institute of Medical Science, Bangalore. Today, I am going to present a paper on etiopathogenesis of vocal cord palsy, a prospective observational study under the guidance of Dr. Smita ST. Introduction of my study. The vocal cord palsy refers to the absent movement of vocal cords. It has a variable etiologies and may be multifactorial and evasive. The cause may be localized to the larynx or may be thorax, neck, or cranial cavity, or even related to various systemic diseases. The aim and objectives of our study: to evaluate the patient with vocal cord palsies, to establish etiological diagnosis based on clinical evaluation. Materials and methods. A prospective study was done in our center from June 2016 to November 2017. 100 patients with vocal cord palsies were identified and examined by using various tests and investigation to establish the etiology. The inclusion criteria included patients visiting or being referred to the OPD ENT in KIMS Hospital, Bangalore, with diagnosis of unilateral or bilateral vocal cord palsies. Patients of both sex and age were included. The exclusion criteria was the patient who did not cooperate for laryngoscopic examination or patient who failed for follow-up. The result of our study. The most common age group affected was 51 to 60, followed by 61 to 70 years of age group. The male showed a slight predominance in our study. 92% presented with change in voice, 27% with a difficulty in swallowing, 27% with cough and aspiration, 15% with mild stride. The unilateral paralysis, 82%, was found to be more common than bilateral paralysis, that is 18%, out of which left vocal cord was more affected than the right vocal cord. In unilateral and bilateral vocal cord palsy, the vocal cord were mostly seen in paramedian position. Now the causes. 38% of patients were diagnosed with carcinoma of larynx, 7% with bronchogenic carcinoma, 2% with thyroid malignancies, 1% with esophageal carcinoma, 28% were idiopathic, and other causes included were traumatic and systemic diseases. The most common iatrogenic cause of vocal cord palsies were found to be thyroidectomy procedures followed by endotracheal intubation. The discussion. The vocal cord palsy and paralysis is common manifestation of numerous diseases. In most patients, unilateral vocal cord is fixed in a paramedian position. According to Woodson, the paramedian position was due to the robust innervation of thyroarytenoid muscle in patient with recurrent laryngeal nerve injury. Left vocal cord palsy were found to be 2 times more common than the right vocal cord palsy due to its long intrathoracic course of left recurrent laryngeal nerve in mediastinum. The similar findings was found in studies done by Ko et al. And Sri Ramponton et al. The most common cause identified in our study was laryngeal growth, leading to mechanical fixation of vocal cords due to mass effect, or infiltration involving the thyroarytenoid muscle in paraglottic space, or invasion of cricoarytenoid joint, or invasion of recurrent laryngeal nerve. These findings are most commonly seen in males due to their chronic smoking and poor dietary habits. The lung cancer with secondary is most commonly affected to the left vocal cord, probably due to the direct compression of recurrent laryngeal nerve by a cancer mass, which was also shown by a study done by Chen et al. The rheumatoid arthritis can also cause vocal cord palsy due to the arthritis of cricoarytenoid joint. Among patients of post-thyroidectomy, vocal cord palsy incidence were 3.5 to 6.6%. Majority of the patients were females because of the high incidence of thyroid disease in females. Next, we are going for the causes of vocal cord palsy following thyroid surgery. It can be due to presence of adhesions, the dearrangement of normal anatomy in recurrent goiters, a huge multinodular goiter that can cause massive bleed during surgery, which makes it difficult for the identification of nerve intraoperatively. A small nodule on the tracheoesophageal groove can also cause compression of nerve, and neuropraxia while searching for the nerves. The intubation-related vocal cord palsies were 0.2%. In our study, it was almost to 3%. The risk factors included are the size of the endotracheal tube. Next one, the cuff of the endotracheal tube. How can this cuff cause? The pressure on the cuff on the anterior branch of recurrent laryngeal nerve comprising the microcirculation and causing ischemic degeneration of the recurrent laryngeal nerve, and lack of deflation of the cuff can cause pressure neuropraxia. Now, next one is duration of intubation, hypotension during surgeries. Neck in a prolonged hyperextension position can cause stretching of both the vagal nerves. Patient being a smoker, one age considering with the degeneration. And the other ones are associated with comorbidities like diabetes and hypertension. In hypertensive patients with atherosclerotic vessels and microvasculature, it is more chance for mechanical damage caused by inflamed cuff. The peripheral neuropathy in diabetes could also be a contributing factor. The conclusion of my study is an integrated diagnostic treatment protocol is necessary for the management of vocal cord palsy. These are my references. Thank you for all.
Good morning, everyone. So myself, I'm Dr. Manoj Kumaran, a junior resident postgraduate in the Department of ENT HNS. So today I'll be presenting a paper on preoperative external branch of superior laryngeal paralysis and paralysis in patients undergoing thyroidectomy by better stroboscopy and objective voice analysis in PHONOCON 2020 conference. So coming to the introduction, so stridor, hoarseness, and voice change are routinely common symptoms and signs of paralysis and paralysis, and stroboscopy is not done routinely for preoperative evaluation of thyroid patients. So video laryngeal stroboscopy handy for detection of vocal cord paralysis preoperatively. That is missed on ideal and laryngoscopy. So diagnosis of this lesion is not easy and it is often overlooked. So need for study, the incidence of invasive thyroid disease is increasing preoperative stroboscopic evaluation of vocal cords is a valuable tool to not only know the external pathology but also to predict the outcome of surgery. The external branch of superior laryngeal innervates the cricothyroid muscle to promote lengthening and thinning of the vocal fold, thus increasing the voice pitch, and if injured, results in loss of range, loss of projection withiness, and vocal pitch. If ABSLN is injured during surgery or any compression of this nerve occurs in malignancy of severe attention thyroid, patient will have transient or persistent changes in the quality of voice, mild huskiness, and dysphagia. The surgeon will have a prior rate of upcoming complications post-surgery and will be in a better hand to explain the patient about the voice outcome post-surgery and to rule out iatrogenic injury. So methodology. So this study was done in a span of 2 years where 47 thyroidectomy surgeries were done and only 28 patients underwent video stroboscopy. So preoperative voice analysis was done, both subjective and objective, and video stroboscopic examination done later. So voice analysis was done by Pratt voice analysis software with low impedance microphone and subjective analysis with GRBS scoring and voice handicap index 30. So this was a hospital-based retrospective analysis of records done after obtaining ethics committee approval, and the inclusion criteria being all the patients with benign and malignant thyroiditis pathology posted for hemi or total thyroidectomy, and the exclusion criteria are the patients with pre-existing vocal fold pathology. So coming to the results, 22 were benign and 6 were malignant. 3 had EBSN paralysis in benign and 0 had paralysis, whereas 5 had paralysis and 1 had paralysis in case of malignant. 68% had normal, 11% had EBSN paralysis, and 4% had paralysis, and other 4% had regular angio paralysis. So mucosal wave and amplitude, it was normal in 90% of the patient and slightly decreased in 10%. In case of EBSN paralysis, 7% had slightly decreased and 4% had moderate decreased. In case of EBSN paralysis, 4% was severely decreased. So glottal closure, 74% of the patient had posterior gap closure, 26% had incomplete gap closure. Vertical plane, 32% of the patient had off plane, that is the paralyzed vocal fold was lower than compared to the normal vocal fold. 32% had bowing of vocal folds, 29% had face asymmetry, 18% had free edge counter, and 29% had irregularity of the vocal folds. So coming to the GRBS scoring, wherein in case of normal patients, everything was normal except for the roughness. In case of EBSL paralysis, grade, breathiness and strain had mild abnormality, whereas roughness and astheria had moderate. In case of paralysis, grade, roughness, breathiness and astheria had severe abnormality, whereas strain has moderate abnormality. Coming to the maximum phonation time. So in case of normal patient, it was 11 seconds. In case of EBSN paralysis, it was 8 seconds. And in case of paralysis, it was 5 seconds. So coming to the jitter shimmer harmonic to noise ratio. So we can see there is an jitter and shimmer was normal in case of normal study. In case of paralysis, it was slightly increased and the harmonicity was slightly decreased. In case of EBS and paralysis, it was further increased. Jitter and shimmer was further increased, whereas harmonicity or noise ratio was further decreased to 6.4. So coming to the voice handicap index 30, where functional, physical and emotional was done and the total scoring was done. Wherein in case of EBS and paralysis, it was moderate abnormality, whereas in case of EBS and paralysis, the OHI was 55, showing moderate to severe abnormality. So clinical photographs showing paralysis are the vertical level of the left vocal fold is at a lower level compared to the right vocal fold. And here we can see there is a bowing of the right vocal fold, suggestive of paralysis. Here we can see there is a short and flaccid vocal folds. Here there is an incomplete phonatory gap, and here you can see the posterior glottis is slightly tilted to the paralyzed side. So here also we can see there is an anterior bowing of the vocal folds with thin and flaccid vocal folds, and here there is a tilting of the posterior glottis with bowing of vocal folds and incomplete closure. So here there is an incomplete closure. This is the voice analysis software showing PRAT of version 6.1.31. There's a spectrogram and the spectrograph showing all the voice analysis parameters, including pitch, intensity, and format, along with the pulses. So the findings suggestive of paresis and paralysis are reduced amplitude and mucosal wave, vertical level is off plane, incomplete glottal closure, and the free edge counter had concavity, open face predominates more equal than closed face. So the summary of EBS and summary paralysis are anterior bowing of the affected vocal fold, short flaccid vocal fold in the affected side. Affected vocal fold's vertical level is lower compared to the normal fold. Mucosal wave and amplitude is reduced, and in mucosal is asymmetrical. Posterior glottis is moved to the affected side. There is an incomplete glottal closure, and there is face asymmetry and irregularity. Coming to the discussion, the human eye can see only 5 meters per second. However, stroboscope allows the eye to see high frequency vibration of the vocal folds by intermittent flash synchronized with the phonation frequency called Tauber's law. So abnormalities in this vibratory pattern becomes more apparent in superior angina palsy, where posterior glottis moves to the affected side because of the tone of the unaffected cricothyroid muscle. The mucosal wave will be asymmetrical as the wave is late in the affected fold with changes in mucosal pattern. So the mucosal wave has a greater velocity and further travels along the mucosal normal fold. The probable cause for these findings is reduced stiffness in the paralyzed cord, which reduces the velocity and extent of the traveling mucosal wave, and stroboscope helps in identifying this mucosal abnormality, which cannot be assessed during video laryngoscope. Though there is improvement in voice even after the nerve is injured, most of these patients cannot produce high-pitched sound. The patient may notice a slight voice change, hoarse, breathy, weak, or diphthongy for transient duration. Later, the voice may normalize with time as the insult is usually gradually attributed to the compensatory mechanism of the opposite normal functioning vocal fold. The moving vocal cord will compensate the hyperreduction crossing the midline to overcome the glottic gap induced by the paralyzed side. Thus, this dysphonia will appear, and the patient and family members will appreciate the normal voice despite abnormal vocal cord function. Subjective and objective voice analysis give a better picture and understanding of the voice pathology and helps in analyzing the post-operative improvement of voice. So limitations are sample size is less, p-by-line statistical correlation not done since it is an active one-quick study and one sample size crosses 50. Pre-op and post-op stroboscopy comparison correlation is planned. Laryngeal EMG intraoperative could have increased their sensitivity. It is operator dependent and findings will vary in beginners unless it is supervised. Conclusion: preoperative stroboscopic assessment using stroboscope is must in all patients. This study suggests that there is an intrinsic relationship between the type of thyroid disease and laryngeal paralysis that is probably related to the local effects of the disease. It is an essential tool to detect palsy, and it identifies the mucosal abnormality which cannot be seen in laryngoscope. And pre and post op is very operator dependent. That is detection, and one may easily miss the subtle changes induced. Hence, initiation and routine practice of stroboscopy will overcome this difficulty. Take-home messages: suspect EBS and palsy in malignant thyroid disorder and suspected benign to malignant transformation. And stroboscope is a very diagnostic tool for detection of EBS and paralysis. References. Thank you.
Good afternoon, everyone. This is Dr. Nisha Sharma presenting my paper on correlation of clinical profile and voice handicap index VHI-10 scoring of patients with hoarseness of voice. That is an observational study. Starting with the introduction part. So the human voice is thought to be an extraordinary attainment which conveys complex thoughts and subtle emotions. Hoarseness of voice can be defined as rough, grating, harsh quality of voice, which is more or less discordant. It is an important symptom encountered in daily ENT clinics. Common predisposing factors include vocal abuse, smoking, and frequent upper respiratory tract infections. When the voice is disordered, impedance to communication increases. It affects whole personality of a person. VHI-10 score measures the influence of voice problems on patients' quality of life. It presents reduced and occasional values in the population who are not having any kind of voice-related complaint. So the aim of this study is to evaluate hoarseness of voice in a rural setup based on its clinical presentation and to correlate it with VHI-10 score. Therefore, the aims and objective of this study was to know the prevalence of hoarseness of voice in rural Haryana and to know the correlation of VHI-10 with hoarseness of voice. The materials and methods, it's a prospective observational study conducted in Department of ENT at SHKM GMC Nallad, Haryana. 60 patients were included as per the inclusion and exclusion criteria. The inclusion criteria was patients more than 8 years of age of both the sexes presenting to ENT OPD at SHKM GMC with complaints of hoarseness of voice. The exclusion criteria was patients having non-hoarse voice disorders, any congenital disorder or mental retardation, cervical spondylosis, osteoarthritis, and Carey spine, in which the neck extension is contraindicated. The patients underwent a clinical diagnosis of hoarseness of voice, underwent a detailed clinical examination, which include indirect laryngoscopy and endoscopic laryngoscopy examination, and all findings were recorded and documented. Correlation with quality of life was calculated by the performer containing 10 questionnaire of VHI 10 scoring, and a score was calculated for each patient based on their experience. The type of sampling was purposive and non-random sampling. The relevant data were collected in a pre-designed data collection sheet of each patient with complaints of hoarseness of voice, and diagnosis was made by history and clinical examination. Now, the result of this study comprised of in a sample size of like 60 patients, we had 70% patients were male and 30% patients were female, and for male was 42 and for females were 82. Age-wise distribution showed the most commonly affected age group was 31 year to 45 year, which comprised 19 patients that represented 31.67% of the population, followed by maximum number included 60 year plus age group, which had 15 patients, and that represented 25% patients. In next chart, we are discussing status of addiction in the patients. So in our study, we saw 58.33% patient, like the number 35 patients were smokers, that included cigarette, bidi, hookah smoking all, and 3.33% patients, n is equal to 2 patients, were tobacco or gutka chewers, and 38.34% of the patients, which were 23 patients, they were not having any kind of addiction habit. Next, we are discussing gender-wise status of the addiction among 60 patients. So out of 60, 37 patients were having addiction habits, in which 94.59% patients, like n is equal to 35 patients, was males, and only 2, that comprised 5.41% of the patients, were females. In the common etiological factors, in 60 patients, we saw 14 patients were having carcinoma larynx, that represented 23.33% of the patients, followed by vocal cord paralysis and vocal cord nodules, that included 13 patients each, that represent 21.67% of the patients, followed by vocal polyp, which included 10 patients, then followed by laryngotracheal trauma 2 patients, vocal cord edema 2 patients, phonatory gap 3 patients, valvular cyst 1 patient, and false vocal cord usage was seen in 2 patients. In gender-wise etiological factor distribution, we saw 100% of the patients were smokers among carcinoma laryngeal group, in which 92.85% patients were male and only 1 was female. The second most common etiology was seen as laryngeal vocal cord paralysis, in which 10 were males and 3 were female, which comprised 76.92% of the male part, and only 23.08% were females. In sidewise distribution of the etiological factors, we saw 38.33% of the lesions were involving both the vocal cord, followed by 35% of the lesions were on left side, and rest 26.67% of the lesions were involving the right side. Among VHI 10 scoring grading, we saw 55% of the patients were lying in the mild grade of the VHI 10 score, which had a score of 10 to 20. So coming to the discussion part of the this paper. So the discussion in Betha et al. Study showed that male to female ratio was 2:1, and Chopra et al. Study had male to female ratio of 1.27:1. In accordance with the published literature, our study also showed that male to female ratio was 2.3:1, therefore concluding the male predominance. Betha et al. Study concluded the most common affected individual were seen in the age group of 21 to 50 years, and Chopra study concluded the most common age group affected was 21 to 60 years. In according to these studies, our study also confirmed the most common affected age group was 31 to 45 years. Chopra et al. Study concluded that males outnumber females in every laryngeal pathology, except in cases of vocal nodules and vocal cyst, where female were outnumbering the males. Amarnath SB et al. Study concluded that male were commonly affected in every laryngeal pathology. In variation with Chopra et al., our study concluded that males are commonly affected and females in every laryngeal pathology. Bethas et al. Study concluded carcinoma larynx was the most common etiology in the OPD patients. Chopra et al. Study showed that vocal nodule was most common etiology. Amarnath SB et al. Study concluded carcinoma larynx is the most common etiology. In accordance with Betha S et al. And Amarnath SB et al., our study also concluded carcinoma larynx as the most common etiology. Chopra et al. Concluded vocal misuse as a common habit and is etiological factor. Betha et al. Concluded smoking as most common addiction. Amarnath SB et al. Concluded smoking as most common addiction. In accordance with Betha et al. and Amarnath SB et al., our study also concluded smoking as the most common addiction. Parekh H reported vocal cord nodule as the most common finding and were bilateral in 91% of the cases. Mehta reported bilateral vocal cord nodule in 100% of the cases. Both the authors also reported vocal cord polyp was most commonly seen on the right side. In accordance with the respective authors, our study also concluded vocal cord nodules were bilateral in 100% of the cases. In variation with Mehta, we reported vocal cord polyp most commonly on the left side. Ahmed R. et al. Used VHI-10 score in their study to assess the impact of vocal cord nodule and polyp on patients' quality of life. They concluded that both male and female had a mean score of 11.6. Our study also concluded a mean score of 17 in both males and female, which is in accordance with the mentioned study. Conclusion. This is the conclusion part, and these are the references which I have taken for this study. Thank you so much. Have a nice day.
Good morning, everyone. Myself, Dr. Priyanka Shillingamar, Senior Resident from the Department of Otorhinolaryngology, St. Stephen's Hospital, Delhi. I'll be presenting in the category of postgraduate award paper presentation. My topic for today is adult epiglottic laryngomalacia, floppy epiglottis. I'll be mainly talking about this condition and its surgical management. Laryngomalacia is a term coined from Greek word malakia, which means morbid softening of part of an organ. It is the most common congenital laryngeal anomaly, which is self-limiting. In adults, laryngomalacia is a rare condition, and main pathophysiology of this condition is due to the increased flaccidity of the supraglottic airway. Adult epiglottic laryngomalacia is a rare condition in which there is a prolapsed or malformed epiglottis, which leads to the airway obstruction. It is of two types, congenital or acquired. I'll be mainly dealing with the acquired condition. It mainly presents with breathing difficulty, foreign body sensation, or occasional swallowing problems. Here is a picture depicting the persistent residual laryngomalacia of the childhood. Here we can see the omega shaped epiglottis, curled up appearance. And this is the picture depicting the floppy epiglottis, which is elongated, touching the posterior pharyngeal wall. And this is the laryngoscopic view of floppy epiglottis, narrowing the airway, touching the posterior pharyngeal wall. Going on to the surgical management, this condition is treated through endoscopic partial epiglotectomy, as I will be discussing about it. It can be either coblation assisted or assisted with using diathermy. Whereas the residual laryngomalacia is treated with supraglottoplasty, similar to the pediatric cases. Here is a video showing the preoperative flexible laryngoscopy of one of our patients, where the floppy epiglottis was touching the posterior pharyngeal wall and narrowing the airway. On deep inspiration, as you can see here, the epiglottis is touching the posterior pharyngeal wall on deep inspiration and narrowing the airway. our experience, a total of 6 patients were included in the study who presented in the outpatient department over a period of 2 years. The age group were above 13 years and above, and the cases were identified on the basis of clinical history, ENT examination, and flexible direct laryngoscopy. Here in the table, as we can see, most of our patients were male and they were in the younger age group. The clinical history, as we have taken from these patients, most of them presented with foreign body sensation, intermittent choking sensation, intermittent breathing difficulty on lying down, and difficulty in swallowing occasionally. The most common laryngoscopic finding in these patients was floppy epiglottis touching the posterior pharyngeal wall. And the surgery done for these patients was endoscopic partial epiglotectomy using diathermy. And most of the patients had a good surgical outcome. Here is a video showing endoscopic partial epiglotectomy. As we can see here, first of all, the lingual surface of the epiglottis was cauterized and tip of the midline, in the midline of the epiglottis was cauterized using bipolar diathermy. And then a midline incision was given, cut was given using monopolar scissors, and either side of the epiglottis was cut and removed around 0.5 centimeter of the suprahyoid epiglottis. Here we can see, after making the midline cut, the suprahyoid part of the epiglottis, either sides were removed around 0.5 centimeter, and the bleeding margins were cauterized using bipolar diathermy, and complete hemostasis was achieved. Here is a picture comparative view of a preoperative patient with postoperative laryngoscopic view. Here the floppy epiglottis is touching the posterior pharyngeal wall, narrowing the airway. Whereas here we can see the trimmed off edges, which are well epithelialized, well healed, of a postoperative patient who had come after 2 months, and the airway is maintained. His symptoms were improved. Here we can see this is a 2 months postoperative picture of the patient during the flexible laryngoscopy. So during postoperative care, patients were kept in postoperative care unit where patients' vitals and saturation was monitored. They were also started on IV antibiotics, analgesics, as well as low dose IV steroids in tapering doses over a period of 3 to 5 postoperative days. And they were started on liquid diet followed by semi-solid diet, gradually to solid diet once the patient was able to tolerate diet. Once the patients were symptomatically better and their condition was stable, they were discharged. We also came across a few complications among the study population. Most of our patients had pain and dysphagia in the immediate postoperative period, whereas none of the patients had difficulty in breathing or postoperative bleeding, whereas 3 of our patients had persistent foreign body sensation during the postoperative follow-up period. Going on to the discussion, majority of our patients were males. 4 out of 6 patients were males with mean age of 34 years. Floppy epiglottis was the most common laryngoscopic finding. The main etiology among all the cases were idiopathic, which was not associated with any etiological factor. The surgical management was done using diathermy-assisted endoscopic partial epiglotectomy, which resulted in improvement of the symptoms and quality of life. The regular follow-up of all these cases were done up to a period of 6 months, which showed improved symptomatic relief. Coming on to the conclusions, adult laryngomalacia is associated with a floppy and elongated epiglottis, which responds well to surgical management. On doing endoscopic partial epiglotectomy using diathermy, we found it is a safe and effective procedure, which improves the quality of life in such patients. These are my references. I would like to thank all my teachers, my seniors, my colleagues, and my head of the department for giving me this chance and to prepare for this presentation. I would also like to give thanks to all my seniors, as well as the organizing committee and the scientific committee for giving me the opportunity to present in the PHONOCON. Thank you.
Good morning to all respected faculty members. I am Dr. Reisa, second year postgraduate student from Basveshwara Medical College and Hospital, Chitradurga. I am hereby presenting a comparative study on the outcomes of early and delayed type 1 thyroplasty following unilateral vocal cord palsy under the guidance of Dr. Prahalada NV. Introduction. Unilateral vocal cord palsy typically presents with dysphonia, shortness of breath, and swallowing difficulties. The etiology are iatrogenic, idiopathic, secondary to trauma, neoplasia, or any neurological disorders. Type 1 thyroplasty is a well-established surgical procedure to manage unilateral vocal cord paralysis to improve voice and prevent aspiration. Aim of the study is to study and compare the results of type 1 thyroplasty depending on the time of surgery, short-term or long-term. Materials and methods. This is an ambidextrous study, and the study population included those patients who presented to our institution with unilateral vocal cord palsy for a duration of 11 years, and the sample size was 32. The patients were grouped depending on duration of symptoms on presentation. 21 patients underwent surgery within 1 year, and 11 patients underwent surgery after 1 year. The preoperative workup included a detailed history, general physical examination, systemic examination, and ENT examination, telelaryngoscopy, flexible laryngoscopy, perceptual analysis of voice quality, acoustic measures of voice quality, aerodynamic measures of voice quality were assessed, quality of life measures in terms of patient self-reporting tools were used, rigid laryngoscopy to rule out other causes of vocal cord fixation were done. The perceptual analysis of voice quality includes Jarpa score, which includes grade of hoarseness, roughness, breathiness of voice, asthenia, and strain, and the scoring was done from 0 to 3. The acoustic measures of voice quality were measured using microphone, which included the fundamental frequency, jitter, shimmer, harmonic to noise ratio. The aerodynamic measures of voice quality included maximum phonation time, where it was asked the subjects were asked to inhale as deeply as possible and then sustain a steady vowel sound of E or A as long as possible. Quality of life measures, the voice handicap index 10 were used, and the impact of voice disorder on different aspects of the patient's quality of life, which is physical, functional, and emotional, were assessed. The self-assessment or scoring was done out of 0 to 4. Telelaryngoscopy, a 10 mm 90-degree rigid laryngoscope or 4.3 mm flexible nasopharyngolaryngoscopy were done. The inclusion criteria was cases of unilateral vocal cord paralysis who were available for the follow-up for the desired period of time. The exclusion criteria included cases of post-traumatic vocal cord fixation, laryngotracheal malignancy, previous vocal cord surgery, multiple cranial nerve palsies, laryngotracheal trauma, failure to follow up, and extrusion of processes. The patient was followed up for a period of 6 months. Intraoperative subjective improvement of voice was assessed, and the patient was asked for follow-up post-op 2 weeks, 1 month, 3 months, and 6 months. The follow-up criteria included telelaryngoscopy, perceptual analysis, maximum phonation time, and vocal handicap index 10. Here is a brief detailing of the surgical technique. Under local anesthesia, horizontal neck incision was done, and the inferior subplatysmal flap was elevated. The deep cervical fascia was divided, and the strap muscles were retracted laterally. The height of thyroid cartilage were measured using calipers, and the thyroid window was incised using a number 15 surgical blade. And the window was created using drill bits, and a celastic block of appropriate size was inserted through the window. The block was adjusted until the patient was satisfied with his voice. After the proper positioning, it was sutured with Vicryl 3.0, and the incision was closed using suture in layers. The results give an idea of the male to female preponderance, and the ratio to male to female preponderance was 26:6. And the age of presentation varied between 19 to 76 years, and the mean age was 47 years old, and the laterality of right is to left was 4:28. Regarding the etiology of the paralysis, right side cases were idiopathic, 1 cases were, and 3 cases of iatrogenic right-sided vocal cord palsy was found, whereas the left-sided, which included 15 cases of idiopathic and 11 cases of iatrogenic causes of vocal cord palsy and 2 cases of mediastinal lesions. Coming to the results part, depending on the Jerba scale, the mean pre-op value of both early and late cases were comparable, whereas the post-op values show a decline in the results, and the decline or the improvement was better in the early subgroup than the late subgroup. Similarly, in the maximum phonation type, the pre-op values were comparable for both early and late, whereas a drastic improvement was found in patients who underwent early surgery than the late surgery. Coming to the voice handicap index 10, patient showed a drastic improvement in subjective assessment, and then it when compared to the late. Results were compared using the telelaryngoscopy, and the findings in patients who underwent the late thyroplasty included varying degrees of compensation, atrophic vocal cord, hanging vocal cord, different levels of approximation with vertical phonetic gap. The results were good in patients who underwent the surgery within a year. The subjective improvement in voice was not satisfactory among delayed group, though the procedure prevents aspiration. Coming to the discussion, the inferior results of type 1 thyroplasty in delayed group can be mainly confined to the high patient expectations, different degrees of compensation by the normal vocal cord, primary etiology, atrophy, and sagging of the paralyzed vocal cord. The limitations of this study was a small study which included the less number of patients, and this is an ambispective study, and we don't have equal number of patients on either side for the proper comparison. There is a selection bias as the patients were operated as and when the patient presented, and complete statistical analysis was not done due to small sample size. Coming to the conclusion, suboptimal results in patients with delayed thyroplasty was found, and early thyroplasty is always better for a better results. And more studies regarding this is required, which includes a larger study group. These are my references. Thank you.
Hello everyone, I Dr. Ritika Chauhan going to present a paper on medialization thyroplasty using autologous nasal septal cartilage and innovation. Introduction. Incomplete glottal closure is defined by lack of joining of vocal folds during phonation. Voice created in this way is quicker, weaker, with air present, sometimes coarse. Another troublesome symptom is significantly reduced phonation time on single exhalation, which causes greater effort related to voice production and fatigue accompanying phonation. The glottic insufficiency is proportional to the intensity of symptoms. The most common cause of unilateral vocal fold paralysis is recurrent laryngeal nerve palsy. Other includes idiopathic, surgical, and non-surgical. Pathophysiology says opening of the vocal cord is achieved by the activity of muscle cricoarytenoides posterior and closing by activity of muscle cricoarytenoides lateralis, interarytenoides, thyroarytenoides. All these intrinsic laryngeal muscles, they are innervated by recurrent laryngeal nerve. In unilateral vocal fold paralysis, vocal fold function cannot be open and close in unison with contralateral vocal fold, which leads to dysphonia, swallowing impairment with aspiration and breathing difficulties due to incomplete glottal closure. Ishiki's initial thyroplasty concept involves removal of the upper border of thyroid ala to place a crude implant, which was inserted through a window in the thyroid cartilage. He described a thyroplasty window that was 10 mm long and 3 mm in width in thyroid ala on the side of vocal fold paralysis. This procedure is done under local anesthesia and can be performed in patients with severe and permanent glottis insufficiency who needs permanent voice improvement by a single procedure. Modification of Ishiki thyroplasty 1 has subsequently been presented with the aim of optimizing the intraoperative surgical time, the positioning of the implant, and the implant materials such as elastic, hydroxylapatite, Vitalium, expanded polytetrafluoroethylene, and titanium implants. Voice disability resulting from unilateral vocal fold paralysis is most commonly managed by voice therapy. If it fails to restore sufficient voice and swallowing function 9 to 12 months following vocal fold paralysis, then surgery is recommended. Aims and objective to evaluate vocal functional outcome following medialization thyroplasty using autologous nasal septal cartilage in unilateral adductor vocal fold palsy, to study post-operative closure of phonatory gap of the vocal folds, to study the improvement in maximum phonation duration pre-operative and post-operative procedure, to study the improvement of post-operative in voice quality, swallowing difficulties, and aspiration. Methodology. This is a prospective study that has been taken with 5 patients who were presented to ENT outpatient department in the year between July 2019 to December 2020, who were diagnosed with unilateral vocal fold paralysis. All patients included in the study were informed about the surgical procedure, expected outcome, possible complication. A written informed consent has been taken from all the patients. 2 patients were diagnosed with idiopathic etiology, 2 with post-thyroidectomy etiology, and 1 with post-tracheal intubation. All patients complaining of change in voice as a consistent symptom without any association of dysphagia, cough, breathing impairment, and aspiration. A detailed functional examination includes proper history, aerodynamic study for vocal fold function, laryngoscopic examination, CT scan, pulmonary function test done to rule out other etiological factors. Those with structural neoplastic inflammatory causes, patient with COPD with impaired lung function, excluded from our study. All 5 patients received preoperative voice therapy for 6 to 12 months period before proceeding to surgical approach. Postoperative assessment of vocal function done by evaluating maximum phonation duration and laryngoscopic examination at 1 week, 1 month, 6 months, and 12 months following surgery. Results. The study includes 5 patients, 4 male and 1 female, in the age group of 20 to 40 years. All came to ENT outpatient department and were diagnosed with unilateral vocal fold paralysis. 4 out of 5 patients show vocal improvement following surgery in the form of complete glottis closure and phonation duration of an average of 15.2 seconds. 1 out of 5 patients show posterior glottal gap with phonation duration of 7.3 seconds and minimum improvement in vocal function. This is a diagrammatic presentation of our result. This is a summary of my result. Discussion. Laryngeal framework procedure, also known as thyroplasty, improves the glottis closure, modify the pitch without any injury to vocal fold mucosa. The main purpose is to achieve full phonation closure at the glottis, followed by improvement in voice quality, elongation of maximum phonation duration, and reduction of effort during speech production. Management of unilateral vocal fold paralysis includes voice therapy, injection laryngoplasty, medialization thyroplasty, arytenoid adduction, and laryngeal reinnervation. Voice therapy and injection laryngoplasty are useful only for short-term period. Medialization thyroplasty is most widely used laryngeal framework surgery as it restores laryngeal function due to insufficient glottal closure, which causes not only a deterioration of voice with reduced vocal efficiency, breathing, cough problem, and swallowing impairment. Medialization thyroplasty involves placement of implant lateral to the inner perichondrium of the thyroid lamina so that vocal fold structural integrity is maintained. In our study, we use autologous nasal septal cartilage because it is easily available, cost effective, less chance of rejection, easily absorbable, low absorption rate, high biocompatibility, minimal tissue reaction, no major complication except for self-resolving endolaryngeal hematoma. Conclusion. Medialization thyroplasty using autologous nasal septal cartilage is most widely used standard procedure, significantly show permanent improvement of subjective and objective functional outcome in unilateral vocal fold paralysis. Now this is a surgical demonstration of the procedure. It involves harvesting of the nasal septal cartilage in one piece and cut it into multiple pieces, largest of size 13 into 4 mm. It can be used further for augmentation. A horizontal incision, neck incision was taken at the level of thyroid cartilage. Platysma is dissected, staph muscles are retracted to expose the thyroid lamina. Now, a perichondrial rectangle window was made at the level of vocal fold, which is 6 mm from the midline, 5 mm in height and 12 mm in length. Then the cartilage window is created subsequently, as you can see in this video. Cartilage graft of size 4 into 13 mm was stuck into the window superficial to inner perichondrium. Then we can suture the graft and suturing done in layers, and we can put a drain for 2 to 3 weeks. Now, this is the pre-operative and post-operative evaluation of laryngoscopic examination. This is the intraoperative laryngoscopic examination.
Data, Punjab, Sindh, Gujarat, Maratha, Dravida, Utkala, Vanga. Jana Gana Mana Adinayaka Jaya Bharat Bhagi Vidata Punjab, Sindh, Gujarat, Maratha.
Laryngoscopic examination. Now, these are the references. Thank you so much.
Good morning all. I'm Dr. Sheila Yosef. I'm here to present on my paper titled Comparative Voice Analysis Outcome in Microlaryngeal Surgery of Benign Vocal Cord Lesions using carbon dioxide laser and conventional cold steel technique. So the key principle in performing microlaryngeal surgery is to understand the unique multi-layered microarchitecture of vocal folds. The superficial lamina propria is vital to production of mucosal wave and thus integral to vibratory characteristics of vocal fold. But it has poor propensity to regenerate after excision or thermal damage. Thus, any surgery should ensure maximum preservation of this layer for optimal healing, minimal scarring and distortion of mucosal wave. Since the advent of carbon dioxide lasers in 1960s, with its favorable wavelength of 10.6 micrometer that allows for concentrating energy in tissues when minimalizing lateral thermal damage, the carbon dioxide lasers have been used in a multitude of ways in laryngeal surgery. Although the use of carbon dioxide lasers in managing benign lesions have been controversial due to the risk of thermal damage, as all benign lesions are seen in the superficial layers. With recent innovations like micromanipulators, softwares like AccuBlade that alter the shape of the incisions, and upgrades that modify delivery of laser beam, it has facilitated better tissue excision in terms of precise cutting and minimalizing damage to surrounding mucosa and underlying structures like vocalis muscle and vocal ligament, which are important source of fibroblasts that are activated during the immediate postoperative recovery phase. This objective is to compare voice analysis outcome in patients with benign vocal cord lesions undergoing microlaryngeal surgery using carbon dioxide laser and conventional cold steel technique and assess the efficacy of laser technique over conventional technique. So we performed a randomized controlled trial at our department, and patients aged 18 years or older with clinical diagnosis of benign vocal fold lesions planned for microlaryngeal surgery were included, with exclusion of those undergoing revision surgery. The patients were categorized into two groups using block randomization technique, and the group A involved patients undergoing microlaryngeal surgery using carbon dioxide laser, and group B involved those going on surgery using cold steel technique. A total of 19 patients have been included in the study. So we performed voice analysis evaluation preoperatively and postoperatively at 1 week and 1 month in both groups. The objective voice analysis was performed using Dr. Speech software version 5.0. The parameters of analysis were fundamental frequency, jitter, and shimmer, and they were analyzed across vowels A, E, and U. The subjective voice analysis was being performed using voice symptom scale questionnaire. The surgery was performed in both groups under general anesthesia by well-experienced surgeons in both of the techniques. The video one shows microlaryngeal surgery being performed using carbon dioxide laser. After taking all laser precautions, the laser beam is being focused, as you can see in the video. After focusing the laser beam, the lesion is pulled towards midline using forceps and is excised. Video 2 shows microlaryngeal surgery being performed using cold steel technique. As you can see, a clean incision being given and raising mini microflaps and excision of the pathological lesion. The video clearly depicts the say that the intraoperative hemostasis is better achieved in performing microlaryngeal surgery using carbon dioxide lasers, as it's been clearly seen in the videos. So the data was collected and it was entered in Excel sheet, and the analysis was performed using SPSS version 22. The statistical tests of analysis performed were repeated measures ANOVA to analyze any significant difference in mean values within each group, and the independent t-test was performed to compare these significance between two groups. So among 19 study participants, 11 participants were in group A accounting for 58% and 8 in group B 42%, with mean age in group A was 40.6 years and that in group B was 43.8 years, with a male to female ratio of 2.17:1, with 68% of the study participants being male. An assessment of parameter fundamental frequency, the mean value showed a decreasing trend postoperatively in both groups, although this was statistically significant for group A across vowel A, and no significant change was noted in group B. In assessment of parameter jitter, it showed that mean value decreased postoperatively in both groups, although this decrease was significant in group A across vowel A and U, and the significant was in group B was across vowel A. The comparison between two groups showed no statistically significant difference between them. In assessment of parameter shimmer, the mean value showed a decreasing trend postoperatively in both groups, although this was statistically significant in group A and B across vowel A, and the comparison between two groups at postoperative 1 month showed no statistically significant difference between the two groups. The analysis of voice symptom scale score showed that the mean values decreased postoperatively in both groups, which was statistically significant in both groups, but the comparison between both two groups at postoperative 1 month showed no significant difference between the groups. Higher incidence was noted in males with a male to female ratio of 2.17:1, as was published in D et al. In 2016, with a male to female ratio of 2.12:1 in their study. Studies by Kumar et al. And Sharma et al. Also depicted a significant improvement of jitter and shimmer within each group, but there was no significant difference between two groups as was seen in our study. Subjective voice analysis in earlier studies like by Mobarsa et al. Using voice handicap index also revealed significant difference postoperatively, but with no comparable difference between the two groups as was seen in our study. Thus, to conclude, comparison of microlaryngeal surgery using carbon dioxide laser and conventional seal technique in management of benign vocal fold lesions revealed no statistically significant difference between the two techniques, indicating both techniques are equally effective in the hands of an experienced surgeon for treating benign vocal fold lesions with comparable postoperative voice outcome. These are my references. Thank you.
I am here to present a case series on a clinical condition which is often missed or misdiagnosed by the young clinicians, but has serious repercussions in the pediatric age group. A stride interstridor cyst in the larynx causing acute airway obstruction. Introduction. In neonates who present with stridor, the etiology is usually congenital in nature. Valvular cyst is a rare cause of stridor in newborn, which may present with respiratory distress, apnea, feed intolerance, and failure to thrive. So, enumerating the causes of stridor: at birth, congenital cyst, glottic web, bilateral vocal cord palsy, congenital subglottic stenosis are some of the differential diagnoses. From 1 week to 6 weeks, laryngomalacia, laryngeal cleft, subglottic hemangioma. Infective causes from 6 months to 2 years like acute epiglottitis, croup, and foreign body. More than 2 years may be foreign body and recurrent respiratory papillomatosis. So what is the aim of this presentation? Through my case series, I would like to highlight that valvular and aryepiglottic cysts can also be a cause of stridor. So the importance of airway assessment in cases of persistent stridor so that you can prevent potentially lethal complications, especially in pediatric age group. In my first case, I had a 4 weeks old baby with a birth weight of 2.7 kg, and he was referred to our center with a preliminary diagnosis of laryngomalacia. So the child had noisy breathing for 3 weeks, which worsened during feed with history of regurgitation. On examination, the weight was 3.4 kg, but which was less than third percentile in the growth chart, which was indicating failure to thrive. The baby was afebrile, but tachypnic. It's a well-maintained saturation, but inspiratory stridor was there at rest too, with suprasternal and intercostal retraction. So expecting or suspecting something beyond laryngomalacia, we went ahead. We evaluated with flexible upper endoscopy, and that revealed a midline cystic lesion in the valvula, which was pushing the epiglottis and the reason for compromise of the airway. So imaging was done to rule out other cystic lesions like lingual thyroid, thyroglossal ductus, lymphatic malformations, etc. You can see that there was a fluid-filled lesion which was narrowing the airway. So the child was in distress. So we planned to excise the cyst under direct laryngoscopy under GA. We shifted the baby to the theater. But what was a challenge in this case? The intubation became difficult in this case, but we did not want to do a tracheostomy for that small kid. So what we did was we proceeded the surgery with a video assisted laryngoscopy, and the infant was skillfully intubated, and thus we were able to avoid a tracheostomy. So intraoperatively, the mass was identified as a large valvular cyst and was excised after initial needle compression, and histopathologically it was confirmed that it was a cyst lined with thin squamous epithelium consistent with valvular cyst. And postoperatively, she made excellent progress with no distress. And even at 4 weeks post-op, she was asymptomatic with adequate weight gain on follow-up. So this is the video which shows that the cyst was the reason for the compromise of the airway, which was seen in the valvula and causing the airway compromise. So this is a pre-op, intra-op, and post-op image. So what was the second case? Again, we had a second infant aged 8 months with history of noisy breathing for 7 months. He was again managed conservatively in the peripheral hospital as a case of laryngomalacia, but he presented with increasing stridor and weak cry. So again, we knew that this was not laryngomalacia or something beyond it. We evaluated using direct laryngoscopy, and it revealed a left aryepiglottic fold cyst which was occluding the airway. So imaging study showed that it was a left aryepiglottic fold cyst which was obscuring the airway. So again, we need a needle aspiration first time, and it revealed 2 to 3 cc of clear yellow fluid which was aspirated initially, and the cyst was excised, and immediate post-op the child had a stronger cry with no respiratory distress. So this is the intraoperative video which shows a left aryepiglottic fold cyst. Intubation was difficult, but video assisted laryngoscopy we were able to secure the airway, and fortunately we were able to avoid tracheostomy in this case too. So this was a aryepiglottic fold cyst. This is a pre-op, intra-op, and post-op image. And this was a child on follow-up, and he was feeding well with free of respiratory distress in the follow-up. So in case 3, again, we had an infant. He was aged 1 month with history of noisy breathing since birth, with history of feeding difficulty, regurgitation of feeds. And on examination, inspiratory stridor was there, which wasn't during feeding, but even present at rest. So this time it was a bilateral valvular cyst, the reason for her symptoms. And under GA, under direct laryngoscopy, the cyst was excised, and tracheostomy was avoided in this case too, and the infant showed dramatic improvement of symptoms. So this is a video which shows that there was a bilateral valvular cyst, which was a reason for her symptoms, and the cyst was excised beautifully. And again, tracheostomy was avoided. This is a child on follow-up with no respiratory distress and adequate weight gain for age. So in case 4, there was a 2.5 kg term male newborn with history of maternal polyhydramnios. He was delivered by C-section, admitted to NICU because of severe cyanosis and respiratory insufficiency that developed immediately after birth. But there was difficulty in intubation. So during intubation, they found out that there was a mass. So shifted to the theater, video-assisted laryngoscopy was done. And this time we again proceeded with aspiration of the cyst, and the child improved after the procedure. So this is a video which shows that the cyst was a reason for his symptoms too. So discussion: valvular cysts are a form of supraglottic cyst accounting for 10 to 20% of all laryngeal cysts. They're typically benign unilocular masses. And as I already said, lingual thyroid, thyroglossal ductus are some of the differentials. And origin, it is said to be either embryological malformation or obstruction of minor salivary gland, much like a mucous retention cyst. And it's a variant of thyroglossal ductus as a different school of thought. So symptoms are inspiratory stridor, which is persistent and might be there even at rest, with cyanotic or apneic spells, with feeding difficulty, failure to thrive. And stridor is relatively a common symptom during the neonatal period. And most of the cases that we come across is laryngomalacia. But inspiratory stridor is also the most common presentation of valvular cyst. So sometimes to complicate the clinical picture, laryngomalacia may coexist with valvular cyst, and the cyst can compress the adjacent epiglottic cartilage and cause the supraglottic prolapse and airway compromise. So larynx in laryngomalacia, as has been beautifully described in the textbook of laryngology, can be compared to a lotus bud which is yet to bloom. So even though all the laryngeal internal structures are fully developed, it is a narrow entrance that causes the problem. But here, mostly the stridor increases with exertion. But in the other cases, which I said, the stridor was there even at rest. So definitive diagnosis can be made with direct laryngoscopic examination, and surgical decompression is a treatment of choice, but simple aspiration might cause recurrence. So what is the take-home message? So the challenge in making an early diagnosis of valvular cyst, especially when laryngomalacia is comorbid, has been reaffirmed in our case series. So whenever you want to diagnose such rare cases, it requires high index of clinical suspicion. You have to carefully inspect the tongue base and larynx using direct laryngoscopy or appropriate imaging modalities when required. Because even though laryngomalacia is the commonest cause of stridor that we come across, the possibility of cyst should be considered and evaluating these cases, because expectant management that we follow in laryngomalacia can detrimentally increase the size of the cyst when missed, causing life-threatening complications. So in that case, intubation becomes difficult and inevitably tracheostomy has to be done. So timely diagnosis and intervention can be life-saving, and the intervention can be as simple as a needle aspiration or a cyst excision. And you can avoid tracheostomy in pediatric age group, because pediatric age group tracheostomy is not expected, is not something that we want. So it provides complete cure. So this is a message for all the young clinicians here. Thank you. These are my references. I am here to present a case series on a clinical condition which is often missed.
Hello everyone, myself Dr. Kalyani Vasekar presenting to you a study of clinical profile of the patients with a benign lesion of the vocal cord. Introduction. As a research quotes, as a human voice, it is the most beautiful instrument of all, but it is the most difficult to play. It plays a pivotal role in our life. According to ICD-79 says, it is a functional difficulty, but it is the social problem too. Most common laryngeal lesions are the benign lesion of the vocal cord, which affect the quality of life. Therefore, the assessment of the voice done by the qualitative and the quantitative way. Qualitative way can lead to a interreliability measures. Therefore, as stated by Almeida, it is necessary to analyze the voice by the objective assessment. Appropriate treatment can lead to the helps in improvement of the quality of life in the patient. So, voice therapy helps to improve in the perceived voice quality, and the gold standard for it is the microlaryngeal surgery. Methods. A presented study was undertaken into the Department of the ENT in SITR GMC Ambajogoi for the period of the 2 years, in which the patients coming to the OPD with the chief complaint of the hoarseness of the voice were included. Sample size taken was the 40, in which 26 were the male and the 16 were the female. Control group contains the 40 males and the 40 females. Most common symptoms observed are the change in voice, hoarseness of the voice, and the heaviness of the voice for the minimum of the 3 months, and the voice fatigue, cough, chronic throat pain, foreign body sensation, and the dryness of the throat. With the participants with the GRAP score of more than or equal to 1 are included into the cases group. And for exclusion criteria for the case group, it is the physiological dysphonia, history of the head and neck surgery, neurological and the pulmonary diseases. On examination, laryngeal papillomatosis, infection, Rinke's edema, and the sulcus vocalis. Inclusion criteria for the control group, it is the age group from 21 to the 50 years of the age, including both the sexes with a GRAP score of 0, and the exclusion criteria for the control group, it is the history of the neurological and the pulmonary diseases, head and neck surgery, and the smoking. Methodology. Detailed history of the each participant was taken into the customized pro forma, and focused on the addiction history, in which the cigarette smoking, bidi smoking, alcohol intake, and the tobacco chewing. The frequency and the duration was noted, with the laryngopharyngeal reflux disease, vocal abuse, vocal misuse, and the allergy. General examination and the otolaryngological examination was performed. Patients with the change in voice or perform indirect laryngoscopic examination. After that, for the confirmation, video laryngoscopy was performed. After that, evaluation of the voice by the speech and the language therapist was done. If the GRAP score of more than or equal to 1 are taken as the cases group. After that, the voice sampling was done. After extraction of the acoustic parameters with the help of trap software, under the parameters assessed are the fundamental frequency, local jitter, local shimmer, and the harmonic to the noise ratio. Results: age and the gender-wise distribution of the patients with the benign lesions of the vocal cord, in which the maximum 22.5% between the age group of the 36 to the 40 years and the minimum 2.5% into the 51 to the 55 and the 56 to the 60 years of the age group, in which the mean age observed it is a 38.3% and the in which the 65% were the males and the 35% were the females. Addiction among the patients with the benign lesions of the vocal cord, in which most commonly observed addiction is the cigarette smoking into the 25% of the patients, and the least common observed it is a tobacco chewing into the 2.5% of the patient, in which in males observed it is the cigarette smoking and in female it is the betel nut chewing. Voice abuse and misuse in patients with the benign lesion of the vocal cord, in which 72.3% of patients were presented with a history of the voice abuse, in which 69.23 were the male and the 78.5% were the females. Clinical presentation of the patient with the benign lesion of the vocal cord, in which 100% patient presented with a history of hoarseness of the voice, in which other associated with the foreign body sensation in 18.18%. Rest are the throat pain, vocal fatigue, and the throat irritation in the 16.66%. Benign lesions of the vocal cord in patients with the benign lesion of the vocal cord are the most commonest it is observed. It is a vocal cord nodule in the 30% of the patient, and the least common it is a vocal cord keratosis into the 12.5% of the patient. So commonest observed in male, it is a vocal cord nodule in 30.78% of the patient, and in female, it is the vocal cord polyp in 35.72% of the patient. Side of the origin of the benign lesions of the vocal cord, it is most commonly affected. It is the right side of the vocal cord in 37.5% of the patient, and the site of the benign lesion, it is the most commonly 40% patient presented with the lesion at the junction of the anterior 1/3 and the posterior 2/3 of the vocal cord, and least common it is 2.5% patient presented with the junction at the junction of the anterior 2/3 and the posterior 1/3 of the vocal cord. Comparison of the acoustic parameters for the vowel A between the different pathologies, in which no significant gender difference into the fundamental frequency, therefore it is not included in it. According to the comparison, we can say that there is no statistical significant difference, therefore it does not tell us any characteristic finding of a particular vocal cord pathology on the acoustic parameter comparison. The results, as we have discussed in detail. Conclusion: in a present study, benign lesions of the vocal cord observed most commonly in the males more than female and prevalent into the 3rd decade of life. Most common addiction associated with it is the cigarette smoking, and the other etiologies like voice abuse and the voice misuse and allergy, reflux diseases. Most common lesion observed it is a vocal cord nodule and the vocal cord polyp. Objective voice assessment could be carried out with the help of the PHAT software, which is convenient, easily available, and the cost effective. And by comparing the acoustic voice parameter with the normative acoustic voice parameter, one could be suspicious of laryngeal pathology in the dysphonic patient. However, it would not be possible to pinpoint the laryngeal diagnosis on this comparison. Thank you.
Good morning, all. I'm Dr. Netra, here to present to you on stroboscopy and acoustic analysis of voice following intubation in otological surgeries. Stroboscopy is an endoscopy that is used to analyze the structure and motion of vocal fold. It enables the examiner to analyze voice as well as evaluate the vocal fold movement simultaneously. In this study, stroboscopy and acoustic analysis of voice has been done to document and analyze the changes in vocal cords of patients undergoing elective endotracheal intubation. The aim of the study was to evaluate voice via stroboscopic examination following endotracheal intubation for otological surgeries. The objectives were to compare and analyze change in vocal parameters and to assess correlation between changes in vocal parameters and endotracheal tube size, duration of intubation, and number of attempts at intubation. It was a prospective cohort study conducted at Department of ENT and Head and Neck Surgery at a tertiary care teaching hospital in South India from August 2015 to June 2018. The inclusion criteria were patients who underwent otological surgeries under general anesthesia with American Standard of Anesthesiology ASA 1 and 2 category with an age group between 18 to 60 years. Patients with previous history of endotracheal intubation and patients diagnosed to have benign or malignant lesions of larynx and patients with obesity and COPD were excluded. Out of the 861 patients who underwent elective otological surgery, 31 were included in this study. All patients underwent stroboscopic and acoustic analysis in the immediate preoperative, 24 hours postoperative, and at the end of the 7th postoperative day. P-value of less than 0.05 was considered significant. The parameters that were assessed included stroboscopic and acoustic measures of voice analysis. These were vocal fold symmetry, amplitude, periodicity, glottic closure, mucosal wave pattern, maximum phonation time, fundamental frequency, intensity, and dysphonia severity index. Coming to the results of the study, a total of 31 patients were included in the study. The mean age was 36.68 years. Gender ratio was 8:23. 61% had normal laryngeal function. 39% had evidence of injury, which resolved by the 7th postoperative day. Statistically significant changes in mucosal wave pattern was observed in the 1st postoperative day. So the mucosal wave pattern, maximum phonation time, and fundamental frequency, which were compared, there were changes in the 1st postoperative day, which resolved by the end of the 7th postoperative day. Stroboscopy enables assessment of voice and vocal fold movements simultaneously. The incidence of laryngeal injury post-intubation has been reported to be 63 to 94% in most studies. In our study, the majority of the patients had normal laryngeal findings. As surgeries to nose and throat will as such cause voice changes, patients who exclusively undergo ear surgeries were only included in this study. The voice problems post-intubation are attributed to the vocal fold cord paralysis, paresis, granuloma, and arytenoid dislocation. The factors influencing these outcomes are ET tube size, cuff pressure, attempts of intubation, number of attempts, and duration of intubation. Stroboscopic and acoustic analysis in the postoperative period help correlate the laryngeal injury with voice outcome. In a study by Mayo et al., they emphasized that the transient voice change associated with the endotracheal intubation is due to the vocal fold trauma. They found that the mucosal wave pattern and the amplitude were decreased in 40% of the patients and were the same in the remaining patients. In this study, mucosal wave pattern in the 1st postoperative day is reduced and found to be statistically significant, but it became normal by the end of the 7th postoperative day. There was no significant reduction in amplitude. The other parameters do not correlate with size of endotracheal tube. No studies have assessed the correlation of size of endotracheal tube, duration of intubation with the acoustic parameters. The duration of endotracheal tube with acoustic parameters was studied in our study, which showed moderate positive correlation between duration of intubation and mucosal wave pattern on the 1st postoperative day, and weak positive correlation between duration of intubation and maximum phonation time, fundamental frequency, and intensity in the 1st and 7th postoperative day. The study throws light on possible glottic injury during endotracheal intubation. So these findings set a protocol for counseling patients with regard to the same. These are my references. Thank you.
morning, everyone. I'm Dr. Deepak. My paper is on quality of life in tracheostomy patients. Introduction: tracheostomy is a life-saving procedure. The prevalence of tracheostomy in ICU patients is around 10%. It is often performed at short notice, and the patients have to take a very quick decision regarding this. The non-verbal communication because of the tracheostomy tube is very frustrating to the patients, and this influences the functional and the psychosocial domains. The aim and objective of this study is to evaluate the impact of quality of life on self-image and well-being of tracheostomy patients, and to assess the components of tracheostomy care involved in the non-ventilated tracheostomy. This is a prospective cohort study conducted between October 2018 to October 2020. A total of 52 patients who underwent elective tracheostomy and did not depend on assisted ventilation were included in this study. Informed consent and ethical clearance was obtained. The quality of life was assessed using 3 international standardized index scales. They are satisfaction with life scale, cannot skip performance scale, and living with tracheostomy index scale. First day of the study is the day where the patient is able to communicate, that is, after the insertion of the fenestrated inner cannula. The reassessment is done on the day prior to the decannulation or on the 3rd month. Satisfaction with the life scale is used to assess the satisfaction with the respondent's life. Each answer will have a scoring from 1 to 7, and the final score will have a minimum of 5 to a maximum of 35. The low score represents poor quality of life, and the high score represents good quality of life. The Kanofsky performance scale is used to assess general functional limitations. The patient or the attender is asked to choose the patient's physical status from the options given in the index scale. It has 10 variables with a scoring from 0 to 10. Final score varies from a minimum of 0 to a maximum of 10. High score represents good quality of life, and low score represents poor quality of life. Then the living with tracheostomy index scale has 11 questions with 3 answers each. First 1 to 6 questions, they represent the functional domain, and 7 and 8 it is about the psychological domain, 9 to 11 about the social domain. The final scores have a minimum of 11 to a maximum of 33. High score indicates poor quality of life, and low score indicates good quality of life. Statistical analysis: mean and standard deviation were estimated for functional, psychological, and social domains. Paid sample t-test was applied to find the level of significance. P-value of less than 0.05 was considered as the level of significance. Results: as told previously, total of 52 patients were included in this study. So based on the indications, there were 22 patients in whom the indication was polytrauma, and for 12 patients, the neurological cause is the reason for the tracheostomy, and in 11 patients, it is cardiovascular causes, and in 7 patients, it is the respiratory causes. And this is the graph showing the initial and final scores of patients from satisfaction with the life index scale. As we can see, on the initial assessment, the mean was 6.67, and on the final assessment, it was 8.17, which has improved. And this is the graph showing initial and final scores of patients from Kanofsky Performance Index Scale. On initial assessment, the mean was 5.94. At the final assessment, the mean was 7.56, where there is an improvement. And this is the graph showing initial and final scores of patients from living with tracheostomy index scale. At the initial assessment, the mean was 28.69, and at the final assessment, it was 18.46. The mean value and p-value of the patients at all the scales. So in satisfaction with the life scale, the p-value at the initial assessment was 6.7, and at final assessment, it is 8.17, with a p-value of 0.02, which is significant. With the Kanofsky performance scale, the initial mean was 5.94. At the final assessment, the mean is 7.56 with a p-value of 0.03. And living with tracheostomy scale, the initial assessment, the mean is 28.69, and at final assessment, the mean is 18.46 with a p-value of 0.00, which is highly significant. morning, everyone. I'm Dr. Deepak. My paper is on quality of life in tracheostomy patients. Introduction: tracheostomy is a life-saving procedure. The prevalence of tracheostomy in ICU patients is around 10%. It is often performed at short notice, and the patients have to take a very quick decision regarding this. The non-verbal communication because of the tracheostomy tube is very frustrating to the patients, and this influences the functional and the psychosocial domains. The aim and objective of this study is to evaluate the impact of quality of life on self-image and well-being of tracheostomized patients, and to assess the components of tracheostomy care involved in the non-ventilated tracheostomy. This is a prospective cohort study conducted between October 2018 to October 2020. A total of 52 patients who underwent elective tracheostomy and did not depend on assisted ventilation were included in this study. Informed consent and ethical clearance was obtained. The quality of life was assessed using 3 international standardized index scales. They are satisfaction with life scale, Kanowski performance scale, and living with tracheostomy index scale. First day of the study is the day where the patient is able to communicate, that is, after the insertion of the fenestrated inner cannula. The reassessment is done on the day prior to the decannulation or on the 3rd month. Satisfaction with the life scale is used to assess the satisfaction with the respondent's life. Each answer will have a scoring from 1 to 7, and the final score will have a minimum of 5 to a maximum of 35. The low score represents poor quality of life, and the high score represents good quality of life. Kanowski performance scale is used to assess general functional limitations. The patient or the attender is asked to choose the patient's physical status from the options given in the index scale. It has 10 variables with a scoring from 0 to 10. The final score varies from a minimum of 0 to a maximum of 10. High score represents good quality of life, and low score represents poor quality of life. Then the living with tracheostomy index scale has 11 questions with 3 answers each. First 1 to 6 questions, they represent the functional domain, and 7 and 8, it is about the psychological domain, 9 to 11 about the social domain. The final scores have a minimum of 11 to a maximum of 33. High score indicates poor quality of life, and low score indicates good quality of life. Statistical analysis, mean and standard deviation were estimated for functional, psychological, and social domains. Paid sample t-test was applied to find the level of significance. P-value of less than 0.05 was considered as the level of significance. Results. As told previously, total of 52 patients were included in this study. So based on the indications, there were 22 patients in whom the indication was polytrauma. And for 12 patients, the neurological cause is the reason for the tracheostomy. And in 11 patients, it is cardiovascular causes, and in 7 patients, it is the respiratory causes. And this is the graph showing the initial and final scores of patients from satisfaction with the life index scale. As we can see, on the initial assessment, the mean was 6.67, and on the final assessment, it was 8.17, which has improved. And this is the graph showing initial and final scores of patients from Kanowski performance index scale. On initial assessment, the mean was 5.94. At the final assessment, the mean was 7.56, where there is an improvement. And this is the graph showing initial and final scores of patients from living with tracheostomy index scale, where at the initial assessment, the mean was 28.69, and at the final assessment, it was 18.46. The mean value and p-value of the patients at all the scales. So in satisfaction with the life scale, the p-value at the initial assessment was 6.7, and at final assessment, it is 8.17, with a p-value of 0.02, which is significant. With the Kanowski performance scale, the initial mean was 5.94. At the final assessment, the mean is 7.56 with a p-value of 0.03. And living with tracheostomy scale, the initial assessment, the mean is 28.69, and at final assessment, the mean is 18.46 with a p-value of 0.00, which is highly significant. And within the living with tracheostomy scales, the functional domain has an initial mean value of 15.98, the final mean value of 9.62, and p-value of 0.04. And with regard to psychological domain, the initial mean was 5.50, and the final mean was 3.0, the p-value of 0.00, which is highly significant. And for social domain, the initial mean value was 7.94, the final mean value was 5.96, and a p-value of 0.0, which is highly significant. The domain-wise analysis, it shows high significant increase in the quality of life at final administration of questionnaire, with regard to all the three domains, that is functional, psychological, and social. Discussion. Most basic needs of the patients, such as respiration, nutrition, and the communication, they are all influenced by the tracheostomy. The significant improvement in quality of life compared to the initial and the final assessment in this study. Kaya et al. Has did a similar study, which has showed that quality of life decreased in the first months after the tracheostomy, and it starts to increase from the second month on, and continues to increase until 12th month. Hammerlit et al. They have did a similar study in tracheostomy patients with head and neck cancers for 3 years. The quality of life in this study was reduced markedly after the surgery, and the adaptation process started after 3rd month. And in 12th month, the patients were adjusted to the new way of life, approaching the preoperative levels of quality of life. In this study, at the final assessment, 22 patients, that is 42.3% of the patients, they were performing tracheostomy care by themselves. Patients who took tracheostomy care independently, their physical appearance has not been affected. These patients had better quality of life. So, training the patients to assume their self-care will improve their quality of life. And tracheostomy causes changes in the physical appearance of the patients. This certainly deteriorates the quality of life, but not to such extent that the life would become unbearable. Men tolerate better than the women, possibly because of the unpleasant cosmetic consequences of tracheostomy for women. Decrease in satisfaction with the spiritual and intellectual life, hobbies, job, and family is seen in all these patients. At the time of initial assessment, all the patients had initial feeding difficulties. At the later stage, 31 patients had no difficulties in feeding, and 21 patients had overcome the initial feeding difficulty. Coming to conclusion, all the tracheostomy patients had poor quality of life across various domains. The functional, psychological, and the social aspects of quality of life improved over a period of time. Patients who had performed their tracheostomy care independently had better outcomes. So psychological assistance is a prerequisite to the comprehensive management and the care of these patients. Thank you.
Good morning. I'm Dr. Sharat Kumar. I'm presenting a paper on microbial isolates in tracheostomy tubes, a hospital-based study. Introduction. A tracheostomy is a surgery in which a trachea is exudated, creating a surgical fistula between the external atmosphere to the tracheal airway. So it is done in order to relieve upper airway obstruction to assist in long-term ventilator support. It's also an alternative way of maintaining airway to improve patients' airway management and decrease the chances of hospital-acquired infections. It's also done in order to relieve the upper airway obstruction by creating a fistula between the trachea to the external atmosphere. So tracheostomy can lead to many complications such as laryngotracheal stenosis, granulation formation, tracheoesophageal fistula, tracheocutaneous fistula, and difficulty cannulation. Other complications include recurrent respiratory tract infection and rarely septicemia. That's why healthcare professionals should be aware of such things in order to prevent critical recurrent respiratory tract infection and septicemia. Tracheostomy tubes harbor microbial organisms on the tube, leading to stomal infection and granulation formation. So these granulation formation can cause bleeding, obstruction of airway and crusting, delay in tracheostomy decannulation, and interference in the tracheostomy function. The aim of the study is to study, correlate, and compare the microbial organisms grown in the culture from the tracheostomy tubes and peristomal granulations in ventilated and non-ventilated patients. Coming to the material and methods, this study was conducted in the Department of ENT Head and Neck Surgery in our institute over a period of past 2 years. The inclusion criteria includes all the patients undergoing regular tracheostomy tube change at our institute of both age groups and sexes. Exclusion criteria includes the patient and attendants not willing to participate in the study. The tracheostomy tube change done on emergency basis. So coming to the methodology, the culture swabs are obtained from the outer cortex of tracheostomy tubes. In case of fenestrated tube, the culture swabs are taken from the fenestra, which is the maximum point of contact with the stoma. And the smears were mounted on 10% KOH to look for fungal hyphae. And these smears are also sent for gram staining and bacterial culture. So the granulation in the stoma and peristomal regions were inspected and graded as follows. Grade 1 is no granulation. Grade 2 is minimal granulation, involving less than 50% of the tracheal stoma. Grade 3 is moderate degree, involving 50 to 70% of the tracheal stoma. Grade 4 is severe or exuberant granulation, involving 100% of the tracheal stoma. Coming to the results, We have seen the total of 100 tricuspid patients, of which a male on more side, with a ratio of 53:47. 38 patients were under ventilator support and 62 patients were under non-ventilator support. Most of the patients who underwent tube change were more than 40 years of age. So the microorganism isolated from the culture tubes. The most common organism being the Pseudomonas aeruginosa in 28 patients, followed by Staphylococcus aureus in 27 patients, and the Streptococcus species in 26 patients, E. coli being in 14% patients, and followed by Klebsiella, Acinetobacter, and Citrobacter in small amount. Distribution of gram staining in tricuspid tubes. Gram negative is seen in most patients of 1440 number, gram positive in 32 patients, both gram positive and negative in 17 patients. There is no growth in 11 patients. Comparison of gram stain in ventilator and non-ventilator patients. We can see in the chart, gram negative is more common in the non-ventilator patients than the ventilator patients. And also gram positive is equally increased in the non-ventilator patients than the ventilator patients. The comparison of the outcomes of gram stain obtained from the tricuspid tube of ventilator and non-ventilator patients is statistically significant with a p-value of 0.003 and is more in non-ventilator patients than the ventilator patients. Comparison of gram stain with the peristromal granulations. So as we can see in this table, majority of patients has in grade 1 granulation, that is no granulation, and 12 patients in grade 2 granulation, that is 50% of the stoma with granulation, and 3 patients in grade 3 and 2 patients in grade 4. So the comparison of gram stain obtained from the tricuspid tube is compared with the peristromal granulation and is statistically not significant with the p-value 0.305. So distribution of fungal smear in tricuspid tubes. 8 out of 100 patients showed positive fungal smear for septate hyphae, of which 1 is in ventilated patients and 7 in non-ventilated patients. So comparison of fungal smear with the peristromal granulations. Of this, only 6 patients were in granulation grade 1, that there is no granulation. 2 patients showed positive for grade 2 granulations and 0 in grade 3 and grade 4, which implies there is no significant correlation between the fungal smear and the peristromal granulation with the p-value 0.6063. So tube change was done on average of 13 days in ventilator support patients and on average of 80 days in the patients on non-ventilator. So, coming to discussion, tracheostomy is a life-saving procedure for patients on prolonged endotracheal intubation. However, tracheostomy is a serious complication that need to be addressed. In tracheostomy tubes, enteric gram-negative bacilli is the most common nosocomial infection in tracheostomy patients. In a study conducted by Acharya et al., they found that Pseudomonas aeruginosa be the most common organism, followed by Acinetobacter. In this study, it's correlating with this above study, where Pseudomonas aeruginosa to be the most common isolate, followed by Coagulus negative Staphylococcus aureus, and then the Streptococcus species. Niederman et al. In this study found that gram-negative organism colonize and form biofilms more in upper airway than the lower airway. Similarly, in this study, gram-negative organism is grown more than the gram-positive organisms. There is no similar study in literature about isolation of fungi from the tracheostomy tubes. In this study, 8 of 100 patients had positive fungal smear who were on long-term tracheostomy tube with double lumen tubes. So this fenestrine double lumen tubes can harbor fungi in tracheostomy tube which are changed after months duration. Yamchuk et al. Investigated on prevention of stromal granulation and tracheostomy tube change as persistence of granulation leads to delayed decannulation and interference in tracheostomy function. According to a study, Staphylococcus species is the most commonly isolated organism from the stromal sites. In this study, we found that the time interval between the tube change increases the grading of peristromal granulation increases. As the study states, tracheostomy tubes to be changed every month to avoid granulation formation, bacterial colonization, biofilm formation. To conclude, the most common organism based on this study is Pseudomonas aeruginosa, followed by Staphylococcus species. There is no significant correlation between the type of the organism with the peristromal granulation. And fungal growth was the most common on double lumen tubes, which is left in situ for more than a month than single lumen tubes. The comparison of fungal smear with peristromal grading is not significant. Most significant factor for the granulation formation is the duration of tracheostomy tube left in situ. Thus, it is recommended that patient and their attendants need to be educated about the need for regular tube change. These are the references. Thank you.
Good morning, everyone. I'm Dr. Usha, final year ENT postgraduate from Sri Ramachandra Medical College. Today, I'm going to talk about the management of unilateral vocal fold paralysis, our experience. Introduction: vocal cord paralysis is caused by paralysis of intrinsic muscles of larynx. It results from injury to recurrent laryngeal nerve. A total of 70 to 80% of injuries are attributed to two causes, which are idiopathic and surgical injuries. The surgical mechanisms vary and include injury from the thyroid, parathyroid, cardiothoracic, head and neck, and neurosurgical procedures. The breathiness of voice is caused by glottic chain, which allows air to escape when the patient attempts to speak. Normal voice production is dependent on proper glottic closure, resulting from bilateral adduction of the vocal folds. This adduction of the vocal folds combined with subglottic air pressure causes the vocal folds to vibrate, causing phonation. Unilateral vocal fold paralysis results in marked changes in voice quality and performance and has a significant impact on quality of life. So the main aim of this study was to assess the vocal outcome and quality of life of patients following surgical and/or conservative management for unilateral vocal fold paralysis. Materials and methods. This is a prospective study including 30 patients diagnosed with unilateral vocal fold paralysis. So patients with the vocal fold paralysis will be subjected to voice therapy for 6 months by two trained speech pathologists, and their results were averaged accordingly. Patients who improved with speech therapy will continue same treatment for 6 months, and patients who do not show any improvement even after 6 months of speech therapy will be taken up for surgical intervention. Patients presenting to OPD 6 months after the onset of vocal fold paralysis will be directly taken up for surgical management. These patients underwent medialization type 1 thyroplasty using the Gore-Tex material. So this image here shows the Gore-Tex material. Video laryngoscopy at first month and stroboscopy and voice analysis at third month post-treatment was performed. The results were as follows. Out of 30 patients, 10 patients had paralysis post-surgery, and in 20 patients, the cause was idiopathic. Out of 30 patients, 17 were found to be male and 13 were found to be female. And 9 patients had right vocal cord palsy and 21 patients had left vocal cord palsy. And GRBA scaling was used, which shows the grade, roughness, breathiness, asthenia, strain scale. They also showed a significant value of P less than 0.001 post-treatment. Nearly all patients had an increase in maximum phonation time as compared to pre and post-treatment. Voice disorder outcome profile was assessed using a questionnaire based on the questions and the symptoms and showed significant changes 3 months post-treatment. On stroboscopic analysis, 97% of the patients had symmetrical vocal fold movement at third month post-treatment. Mucosal waveform and glottis closure was present in 29 out of 30 patients 3 months post-treatment. This shows a stroboscopic image of the left vocal cord paralysis preoperatively. So this is an image which shows a preoperative adduction and abduction, and this is the post-operative adduction and abduction. So we can see there is a post-operative improvement in stroboscopic analysis. Discussion. Video laryngostroboscopy with voice analysis aids in the diagnostic and deciding the mode of management of unilateral vocal fold paralysis. They are also helpful in detecting the changes visually and acoustically pre and post treatment. Only patients with unilateral vocal fold paralysis, which cause significant dysphonia as they disrupt normal vocal cord vibratory function, were considered. Management of vocal fold paralysis and restoration of the vocal cord function and optimizing the voice are the goals in the treatment. So we moved on with the psychoacoustic evaluation of the voice, where the expected voice outcome following the treatment for the unilateral vocal fold paralysis was excellent. And most patients resumed normal speaking activities and functions are able to meet all the normal voice demands. Voice disorder outcome profile was done, which showed a significant value of P less than 0.001, which was achieved post-treatment, showing a tremendous improvement in physical, functional, psychosocial abilities of each patient. The stroboscopic voice analysis can be clearly defined and evaluated as shown in the study, and subtle changes in voice can be picked up only after an adequate period of healing. Hence, significant changes were noted only after 3rd month post-treatment. On stroboscopy analysis, we looked for the symmetry, the mucosal waveform, and the glottis closure. On looking on the symmetry, it revealed that all the patients pre-treatment had asymmetrical vocal fold movement, and 97% of the patients had symmetrical vocal fold movement following treatment at the 3rd month post-treatment. Mucosal waveform and glottis closure was present in 29 out of 30 patients 3 months post-treatment. Hence, stroboscopic analysis, psychoacoustic analysis, and voice disorder outcome profile complement each other on the means of diagnosis and management and follow-up of patients with unilateral vocal fold paralysis. So, on conclusion, we can decide that both surgery and speech therapy plays a major role in treating the patients with unilateral vocal fold paralysis. Thank you.
Good morning all, this is Dr. Jerry Kashwin and I am presenting a paper on the role of fiber optic laryngoscopy in the management of congenital stridor or experience. Coming to the introduction, stridor is an abnormal noisy breathing that occurs due to turbulent flow of airway through passage of obstructed airway. Congenital laryngeal anomalies present with congenital chronic stridor. Common etiologies include laryngomalacia, bilateral vocal cord palsy, and subglottic stenosis. Digital laryngotracheal bronchoscopy has been the gold standard investigation for the evaluation of cases and the requirement of general anesthesia, and it has its own limitations. Flexible fiber optic laryngoscopy is a relatively less invasive output procedure which can be used as an alternative without compromising the outcome. In this study, we have reviewed and analyzed our experience in children who have presented with chronic stridor etiologies in management using fiber optic laryngoscopy. The aim of the study is to discuss the role of fiber optic laryngoscopy in children who present with chronic stridor and their etiologies and their management. The inclusion criteria are the children less than 5 years of age with chronic stridor were included, and the exclusion criteria were the children who had previous history of intubation, acute onset, and those with diseases or anomalies of nose, nasopharynx, and oropharynx, and patients with known case of stridor diagnosed elsewhere were excluded from the study. The methods were, it was a retrospective study, and clinical data were included from the hospital from the year of 2010 to Jan 2020. And all children were included who were less than 5 years of age. 40 patients were included in the study and further evaluated, and the data were analyzed for gender, age indication, cause and etiology, and the results for endoscopy, comorbidities, and if tracheostomy is required or not. The procedure is all the patients will underwent flexible fiber optic endoscopy either in an office setup or operation theatre depending upon the severity of stridor. Fiber optic laryngoscopy of 3 mm width was used in all children. All the patients were assessed under topical anesthesia without sedation, and the child was placed in supine position. Transnasal, the nasopharynx, the laryngeal inter, the glottis, the subglottis, and the trachea was assessed. The functional assessment of the upper trachea was possible as the patients were breathing normally. The results were the mean age of the study population was 23 months, and out of 40 children, 26 were male and 14 were female. In this, the most frequent cause of stridor was laryngomalacia, which was seen in 32 patients, which was 80%, followed by laryngeal web, seen in 7.5%, and laryngeal hemangioma and subglottic stenosis in 5% of the patients, and bilateral vocal cord palsy in 2.5 patients. Laryngomalacia was further classified based on the Ollinger classification to 3. In our study, type 1 was found in 22 patients, type 2 in 6 patients, and type 3 in 4 patients. And the type of intervention were in 40 patients, 9 patients required active surgical intervention, and the rest of the patients were managed conservatively. This is the table showing the number of patients in each category who required surgical intervention and type of intervention. In diagnosis of laryngomalacia, number of cases required in surgical intervention 3, and the surgery done was laser-assisted arytoglottoplasty. In bilateral vocal palsy, the patients required intervention was 1. In the patients underwent laser corectomy. In congenital subglottic stenosis, the surgical intervention were 2, and they underwent laser-assisted endoscopic excision of stenotic segment. In laryngeal web, the patients required 3 patients required surgical intervention, and endoscopic release in 2 patients were done, and open release via laryngofacial in 1 patient was done. In subaortic hemangioma, there were no patients requiring surgical intervention, and it was managed conservatively. Coming to the number of patients who were tracheotomized, 6 patients required tracheostomy to relieve stridor or as a preliminary intervention prior to definitive treatment. All these patients were successfully decannulated later at varying intervals. The time taken for decannulation was almost from 1 month to 2 years, and none of the patients in the study had synchronous airway lesions. In case of bilateral abductor palsy, MRI brain was done to rule out Arnold-Chiari malformation. So the number of patients tracheotomized was 6 patients. And this is a picture showing type 1 laryngomalacia in FOL. And the second picture is thin glottic pleb. And the third one is the keel in the glottis. Discussion. The management of congenital chronic stridor is usually conservative and is important to identify the etiology to avoid early morbidity and mortality. In this, laryngomalacia was the most common cause of stridor, accounting up to 80% of all the cases. Mean follow-up these patients were almost 2 years, and none had stridor in the post-operative period, according to Friedman et al. So Altman et al. Reported that the tracheostomy and endotracheal intubation were required in 13 patients and 39% of patients, respectively. So Altman et al. Also reported that the tracheostomy and endotracheal intubation were required in 1 and 39 patients. And the study also showed that the flexible fiber optic laryngoscopy is a valuable tool for assessing the airway, ability to assess the dynamic functions of the larynx and trachea without general anesthesia, and makes it an ideal tool for initial assessment of patients with stridor, especially in the case of laryngomalacia and vocal cord palsy. Transnasal assessment also helps in assessing the presence of synchronous nasopharyngeal lesions. And in this study, we did not observe any synchronous airway lesions in these children, which is at the odds to the other investigators. So conclusion, flexible fiber optic laryngoscopy is a valuable tool in diagnosing the dynamic evaluation of the chronic airway obstruction, and can be done under topical anesthesia and gives a comprehensive analysis of the airway, thus avoiding a microlaryngobronchoscopy and morbidity of the general anesthesia in pediatric age group. And though laryngomalacia is a common cause of stridor, other rare causes should be excluded, and prompt and early surgical intervention wherever necessary must be done, and which reduces mortality and morbidity. So these are my references. Thank you.
Good morning, everyone. I'm Dr. Amna. I'm here to present my paper on the assessment of swallowing in patients with stroke using flexible endoscopic evaluation of swallowing of fees. So, stroke is the second leading cause of disability and death in India, with almost 119 to 145 patients per 1 lakh population being affected with stroke. And we have seen that there is 37 to 45% of the patients with stroke have dysphagia. So undetected dysphagia can lead to malnutrition, to silent aspiration, and to aspiration pneumonia. So it's important for healthcare professionals to perform early dysphagia screening for early diagnosis, early initiation of treatment, and to plan for the rehabilitation techniques. So the current available screening tools include a bedside oral swallow test and an instrument-based test such as FEES and a video fluoroscopic swallowing test. So the aim of our study was to evaluate the usefulness of FEES as a routine diagnostic modality in starting oral feeds in stroke patients, and to compare FEES with GUS, a bedside clinical swallow test, and to correlate dysphagia with the territory of stroke. So we conducted this study in the Department of ENT, Neurology and Speech and Language Hearing Sciences. This was an observational study done over 2 years, and the inclusion criteria mainly included patients over the age of 18 years. They should have stroke, be on supportive nutrition, be fully conscious and alert, be able to understand and communicate, and to sit independently or at least with support. So once the patient was diagnosed to have stroke, the territory of stroke was identified by MRI and categorized into an anterior and posterior group. Daily clinical assessment was done by the neurologist, and if fit neurologically to resume oral feeds, they were referred to the ENT surgeon and to the speech language pathologist for dysphagia screening. And a clinical swallow test was done by the SLP, and it was followed by a FEES done by the ENT surgeon. So food of 3 different consistencies were used from locally available and culturally accepted food, and edible food dyes were used for better visualization. So the GUS included 2 components, an indirect and a direct swallowing test. Indirect swallowing tests require the patient to be alert and have voluntary cough and to have saliva swallow. Only if they passed the indirect test was the direct swallowing test done. And this looked for involuntary cough, drooling of saliva, and voice change after a swallow. If all three components were positive, they were found to have dysphagia and unfit to resume oral feeds. And then the patient underwent fees, which was done by an ENT surgeon who was blinded to the results of the clinical swallow. It was either done bedside or in the ENT clinic. The findings and the decision of fees was noted, and if there was a discrepancy between fees and Gus, the decision of fees was final. So this was our setup. This were the instruments used, and this is the technique of performing fees. So we analyzed the results by using Yale's pharyngeal residue score, which looked and graded the residue in the vallicula and in the pyriform sinus. And we also used the penetration aspiration score by Rosenbeck to grade objectively the severity of aspiration. So coming to the results of our study, a total of 35 patients were included in the study. And there was almost equal representation between the anterior and posterior circulation of strokes, and the sex ratio was 2.5:1 with a more slightly higher male preponderance. So coming to the outcomes of Gus, 100% of the patients had passed the indirect swallow test and were fit to undergo further screening, while 14.3% of the patients had failed the direct swallow test and were deemed unfit for swallow. But when we analyzed using fees, we found that 48.6% of the patients were found to have an unsafe swallow, with an almost equal representation between the anterior and posterior circulation strokes. So further, we analyzed the pharyngeal residue based on the territory of stroke, and we categorized the pharyngeal residue into two groups, which is no trace residue or mild, moderate, severe groups. So we found that there was no association between the territory of stroke and a vallicular residue, and there was no association between the territory of stroke with the pyriform sinus residue. And we also analyzed the penetration aspiration score based on the stroke territory, and we found no significant association between the territory of stroke and the penetration aspiration score. However, we found that when we analyzed the pharyngeal residue with the penetration aspiration score, there was a significant association between the vallicular residue and the pyriform sinus residue with the penetration and aspiration score. So then we compared fees and Gus, and we found that Gus had detected more posterior circulation strokes, while fees had detected both anterior and posterior circulation strokes. So Gus versus fees were then compared, and we found that fees had detected all 5 patients which Gus had deemed unsafe, whereas Gus had missed 12 patients with dysphagia, of which 7 were anterior circulation strokes and 5 were posterior circulation strokes. And we also compared and analyzed to know the average number of days for the initiation of swallow, and we found that anterior strokes recovered early, that is by 23 days, while posterior circulation strokes recovered late on an approx 56 days. So to summarize, dysphagia was diagnosed on fees if they had a high vallicular residue and or a pyriform sinus residue score, and if they had a higher penetration aspiration score of 5 and above. And in our study, we found that higher pharyngeal residue had a higher penetration aspiration score, and the vallicular residue was more significant, and there was no territorial preponderance for pharyngeal residue and the penetration aspiration score, meaning dysphagia was equal in both anterior and posterior circulation strokes. But we found that Gus detected dysphagia in posterior circulation better compared to the anterior strokes, but Fees was able to detect dysphagia in both anterior and posterior circulation strokes. And a systematic review and meta-analysis was done, and there were studies which showed that Fees had a greater sensitivity for detecting aspiration compared to video fluoroscopic swallowing study. Thus, Fees is widely preferred and accepted. It's less cumbersome, cost-effective, easy to do, and there was no risk of radiation exposure or repeated testing, and it's a safe procedure. There was no complications reported in our study. So we conclude that routine screening for early detection and management of post-stroke dysphagia must be done. Anterior strokes were found to recover early compared to posterior strokes. FEES should be the first choice for dysphagia screening in strokes, especially in well-equipped tertiary care centers with access to a trained speech-language pathologist and an ENT surgeon, and with a fiber optic laryngoscope. GUS is not that preferred, but it can be done only for posterior circulation strokes if they have resource constraints or there is a specialist or instrument deficient scenarios. Thank you.
Hi, I'm Amrita. I'm a speech language pathologist from Kerala. I'm here to present my research work on vocal self-perception of singers while singing using mask. Wearing a face mask is one of the strategies that we all have using in order to prevent the infection of coronavirus. There are various types of face masks that is currently available in the market, in which the most recommended ones were the surgical N95 and 3-layer cloth mask. Literature have shown that these face mask has various effect on the voice. Especially usage of face mask can result in attenuation of voice. Also, there will be an incoordination between the respiratory, phonatory, and articulatory system, and visualization of articulatory system will get hindered. Also, vocal adjustments will become inadequate, and all these will lead to an excessive muscle tension. As a result of all these changes in the vocal mechanism, there are chances of developing voice problems, discomfort, and sometimes behavioral dysphonia. So these findings in the literature leads to the idea for the current study. That means the aim of the study is to evaluate the effect of using mask while singing on self-perceptual voice characteristics of choir singers. So in order to conduct this study, first we developed a questionnaire with 4 sections, and section 1 contains demographic data of the participants. In section 2, we have developed a set of questions which addresses the vocal experiences of the singer while singing using a mask when compared to singing without a mask. And in section 3 and 4, we have used a standardized questionnaire called vocal fatigue index and a standardized scale called vocal tract discomfort scale. And these were transformed into Google Forms and were given to choir singers. We have received around 30 responses from various choir singers within the age range of 15 to 50 years. The results were analyzed statistically using descriptive statistics as well as on-way ANOVA and independent t-test. This is the result of analysis of the section 2, that is the voice experiences the choir singers had while singing using mask. So what we have found is like shortness of breath, reduced vocal endurance, and reduced clarity was the problems experienced by majority of the choir singers, and followed by issues like shallow breathing, difficulty to maintain loudness, muffled voice, effortful articulation, as well as altered auditory feedback. And very less number of people have reported a difficulty to vary pitch. And there is an important finding that we have got is like no one have reported that they haven't found any difference when they sing with mask and without mask. That means singing with mask is making one or other change in their vocal mechanism. And this is a result that we obtained from vocal fatigue index. In vocal fatigue index, what we have found is like people have reported that they are having more of fatigue related issues while using mask when singing. Especially they have said like they are feeling it is more effortful when they sing using a mask, as well as the voice becoming weak, hoarse, and also they are limiting their talking time when they feel like it's a day to sing using their mask. So, and it is also found that they are not avoiding any of the situations because they have to sing using a mask on. And this may be because of the reason that all the issues they are feeling is getting resolved with rest. Because in the last 3 questions, which addresses whether their problems are getting better with rest, majority have said a yes. That means even they have found that their overall voice as well as the quality is improving when they're taking adequate rest. So these findings in vocal fatigue index are actually coordinating with the findings that is already there in the literature. That means in the literature it has been found that vocal fatigue is something that will get better with rest. So that is what we have also found in our study. Also, the findings that we got from vocal fatigue index is in accordance to the findings that we got in our second section, that is boys experiences what they feel when they sing using their mask on. That means it's been found that vocal fatigue can lead to vocal loading because of effortful production of voice as well as a reduced flexibility, pitch range, and vocal projections. These are the points that the singers have mentioned when we ask them to self-rate the problems that they are experiencing. And this is a result of vocal tract discomfort scale, in which we have got like most of them have reported irritability, dryness, soreness, tightness, and aching when they sing using the mask on. And when we look on to the severity of the symptoms reported, it has been found that majority are reporting a mild level of severity. Very few have reported extreme tightness when they sing using a mask on. We also try to find out whether there is any relationship between the type of mask used and the effect it has created on the vocal system. And we got a significant difference between the domains like vocal fatigue, frequency, and intensity of discomfort with the type of mask used. That means in double mask, which is in which they have used a combination of N95 and disposable, are having more effect on the voice system when compared to the disposable mask, N95 mask, and cloth mask is having very least effect. When try to compare the variables like age, gender, years of experience, duration of singing, history of voice problem, usage of mic, and usage of warm-up exercises on this voice issues, it has been found that they don't have any effect. That means, despite of all these factors, all the people, all the choir singers were experiencing one or other kind of voice issues when they are using mask while singing. So this draws into a conclusion that wearing mask while singing has a very significant effect in singer's voice, and this can be due to the increased perception of vocal effort, difficulty in speech intelligibility, and altered auditory feedback that the wearer is having because of this mask. So it's very important to devise specific vocal hygiene tips and other management options, because mild, even though it is a mild degree of problem each of them are experiencing, a long-standing mild problem can lead to a voice issue in the future. So that's all about the presentation. Thank you. Have a nice day.
Greetings to one and all. The topic that I'm going to present today is determination of voice parameters sensitive to identify vocal changes in individuals with dysphonia, a preliminary study. Authors, myself, Ashla Gurukarachin, followed by my co-authors, Dr. S. V. Narasimhan and Ms. Sahanaki, Department of Speech Language Pathology, JSS Institute of Speech and Hearing, Mysore. Now, we'll move on to the introduction. Literature review reveals that multiparametric assessment of voice play a vital role in the assessment of dysphonia. However, to determine all the perceptual and objective parameters is time-consuming and it also expensive. Therefore, it is important to identify the set of voice parameters that are sensitive to identify the vocal changes in individuals with dysphonia. Determining a standardized set of voice parameters can reduce the clinical workload, and clinician can also better judge the treatment outcomes and progress in patients. There are two objectives in our study. The first one is to investigate the subjective and objective measures of voice in individuals with dysphonia and normal controls. The second one is to identify the set of parameters among both subjective and objective measures of voice that are sensitive to vocal changes in dysphonia using a discriminant analysis. We'll look into the methods and materials included in the study. Participants in our study were divided into Group 1 and Group 2. Where participants of the Group 1 are the individuals with dysphonia, There were 10 males and 5 females with the age range of 30 to 50 years. They were diagnosed as having a voice disorders secondary to any organic pathology such as vocal nodule or polyp. The diagnoses were established based on an evaluation done by an otolaryngologist. A voice evaluation done by an SLP revealed the presence of hoarse voice quality with a severity ranging from mild to severe degree. Participants in the group 2 were the individuals with normal voice. There were 15 participants, and these participants were aged and gender matched with the group 1 participants. They had clinically normal voice with no history of voice disorder or vocal abuse or vocal misuse behaviors. The participants in our study were taken from convenience and purposive sampling. Both participant and examiner were seated in a sound-treated room. Participants were instructed to phonate a sustained vowel, that is A, E, U, A, E, and U, for 3 times at their habitual pitch and comfortable loudness level. Dynamic microphones were placed at 15 cm away from the participants' room. Recording and analysis were made by using a Pratt software. Data analysis includes subjective analysis and objective analysis. So in subjective analysis, GRBS rating scale were considered, and randomized phonation samples of all the participants were rated by an experienced and qualified speech-language pathologist. Objective analysis, Pratt software were used for the acoustic, capsular, spectral parameters of the voice, and doctor-speech vocal assessment were used for the EGG parameters. Subjective parameters involves grade, roughness, breathiness, asthenia, and strain. Where acoustic parameters includes fundamental frequency range, mean intensity range, jitter percentage, jitter PPQ5, shimmer APQ5, HNR, and NHR. Capsular and spectral parameters involve CPPS, H1H2, H1A1, H1A2, and H1A3. EGG parameters involves contact quotient, contact index, close ratio, open ratio, contact quotient perturbation, contact index perturbation. Statistical analysis. The data of our study falls under the non-normal distribution. For subjective parameters, percentage of ratings, the median, range, minimum, and maximum values obtained in each category were considered. Chi-square tests were done to check the significant difference obtained between the ratings of dysphonic and normal voices on the GRBA's perceptual evaluation. The objective parameters, mean and standard deviation values for all the objective parameters of both the groups were considered. Univariant ANOVA was done to check the significant difference in the mean values of each objective parameters between the two groups. Discriminant analysis was done to find out parameters that can discriminate between two groups, that is dysphonia and the normal control. Now we look into the results. For the subjective measures, in the normal group, all the samples were rated as normal rating on all the perceptual parameters. In the dysphonic group, none of the samples were rated as normal, where for grade, roughness, and breathiness, most of the voices were rated as moderate degree, where for the asthenia and strain, most of the voices were rated as mild degree. Chi-square test revealed significant difference in all the perceptual parameters between the participants of both the groups. Acoustic parameters for mean intensity and intensity range showed no significant difference between both the groups. Where fundamental frequency range and HNR showed significantly lower values in dysphonic group, while jitter percentage, jitter PPQ5, shimmer APQ5, and NHR showed significantly higher value in the dysphonic group. And for the capsular parameters, CPPS showed significantly lower value in the dysphonic group, while spectral parameters such as H1 and H2 and H1 and A1 showed significantly higher value in the dysphonic group, followed similar results for EGG parameters for CQP and CIP. In discriminant analysis, all the 24 parameters were considered as a predictor variables, but among that, only 5 parameters were considered as a significant predictors, such as grade, roughness, shimmer APQ5, CPPS, and CIP. 100% of samples were classified accurately as either dysphonic or normal by these 5 significant predictors. Past investigators have concluded that there is not a sole measure or a single instrument that is involved to evaluate voice. Considering the multidimensional nature of voice, the multiparametric approach incorporates various parameters of voice. Most importantly, the results reveal that among all the subjective and objective parameters considered in the study, the combination of only 5 parameters, that is grade, roughness, shimmer APQ5, CPP, CPPS, and CAP, discriminated the dysphonic and normal voice samples with 100% accuracy. Results were in accordance with earlier studies and reconfirmed that both the subjective and objective measures were important in discriminating the dysphonic voices from that of a normal control voice. From this, we can conclude that since the present study was a preliminary report, future investigation may help to determine the relationship between the specific subjective and objective parameters of voice identified in the present study, can provide more penetrating and ample in-depth insights into the diagnostic distinctions between various voice disorders. These are the references. Thank you. Greetings to one and all. The topic that I'm going to present today is determination of voice parameters sensitive to identify vocal changes in individuals with
A very good day to all the participants of PHONOCON 2022. My name is Sandra Santosh, and I shall be presenting our paper titled Development and Validation of Xerostomia Inventory for Glossectomy, a preliminary study for speech-language pathologists. So cancer has been causing endless difficulties, including physical as well as psychological concerns for not just the patients, but as well as their caregivers. And patients often have to undergo various procedures like radiation therapy, chemotherapy, and pharmacological interventions, where they often report issues associated with drying of mouth, which leads to difficulties with not being able to speak and swallow up sufficiently. This has also been attributed by statistics which have been done across the Dutch population, where they report that 79% of the population had swallowing issues, while 55% had speech-associated issues. Hence, this abnormal drying of this mouth is known as xerostomia, and several researchers have reported regarding xerostomia and the quality of life, how it is affected in xerostomia patients, as well as develop multiple questionnaires, rating scales, and inventories regarding identifying patients with xerostomia. And all these researchers that have been done give us a very good reliability across the inventories that have been developed, as well as across the population that the inventories have been carried out across on as well. And although these researchers and inventory give us very good idea about the effects of xerostomia from a medical point of view, there has not really been any studies that have actually addressed our speech and swallowing aspects that xerostomia affects as a whole in terms of a perspective of a speech-language pathologist, which is where we come to our need of the study. So being a speech-language pathologist, it is extremely important to understand the contribution that of xerostomia that it has on our speech and swallowing and the difficulties that patients face due to xerostomia, so as to carry out efficient and appropriate intervention. Hence, this is a preliminary study that has been undertaken to develop and as well as to address this lack of perspective that is there, as well as to evaluate the effects of xerostomia in glossectomy patients in the field of speech and language pathology, which is our aim as well. So building an inventory that will help us in rating the amount of xerostomia and its effects across speech and swallowing aspects. Our method involved reviewing existing literature to create our inventory, which we divided into 5 different domains that were in regard to our speech and swallowing aspects. We had our oral health domain, swallowing domain, movement of articulators domain, voice and intelligibility of speech domains. Content was validated by 3 different speech language pathologists across that are from the field of head and neck cancers. The study included 25 patients from the age groups of adults and geriatrics, as well as normal control groups of 25 participants. The participants were given prior consent and were included based on the following inclusion and exclusion criteria. The data was collected using Google Forms and telephonic interview, and all the participants were given appropriate instructions regarding the interview during administration of the inventory. The data was then considered, and then a statistical analysis was done using SPSS software. Now I'll be talking about the results. in particular, the results across each of the 5 domains, beginning with our oral health domain. So our oral health domain had around 27 sub-items. And as you can see from the graph and as well as the table, the Cronbach's alpha score was around 0.92, which indicated an excellent inter-reliability across the domain, as well as across the items, amongst the items as well. So, and these results were at par with the study conducted by Hohenberger et al. In 2019, where he studied the oral health aspects that xerostomia affected in cancer patients. Then the second domain, which is our swallowing domain, had 5 sub-items. And as you can see, the Cronbach alpha is 0.919, which again is at par with the recent study conducted by Villa in 2019, indicating higher reliability and excellent internal consistency among the samples and the items. The articulation analysis using the Cronbach's alpha gave us around 0.95, which was at par with our Pai et al.'s study that was done in 2001, again showing good reliability and internal consistency among the 13 items that are in the domain of articulation. The voice domain, which had 6 questions, 6 particular statements and questions regarding the how xerostomia affects voice, again showed a Cronbach's alpha of around 0.948, showing very good reliability and internal consistency, which was correlating with our Pai et al.'s study in 2001, as well as Nascimento's et al.'s in 2019. The final domain, which is our intelligibility domain, as you can see from the graphs and the tables, which had 15 sub-items, had a Cronbach's alpha score of 9.76, again showing very high reliability and internal consistency, which correlated with Baker et al. Study in 2006. So when you look at the overall domains and overall severity data that was analyzed, we got a Cronbach's alpha of 0.96, which again shows very high reliability and internal consistency, which is a very good basis to further improve this inventory, further use this inventory to rate the severity of xerostomia across patients and to see how it is affecting these different areas of our speech and swallowing aspects. Which is, when concluding, this study gives us the fact that xerostomia is one very important factor that an SLP needs to consider when carrying out assessments, as well as to properly understand management and counseling strategies. Counseling indicating towards hygiene, both oral and vocal, to improve the speech and swallowing aspects should also be taken into consideration. A study is a gateway for new insights towards this particular issue, and further researches can be initiated by speech-language pathologists in collaboration with several medical professionals to understand the effects of xerostomia in cancer patients. The limitations of our study include that only one area of head and neck cancer was targeted, which was our cancer of the tongue, and implementation can be done in detail across other types of head and neck cancers as well, and its associated xerostomia. And another limitation was that a limited data availability of only 25 participants were in the study that we have conducted. Future implications include a comparative analysis across different types of head and neck cancers, not just glossectomy, as well as gender and age-wise differences, because when you consider gender-wise implications, there have been studies that quote that females tend to have more effects with xerostomia, and when considering age-wise, more of the studies have targeted our adult and geriatric population. So we can also consider that as a future implication as well. These are our references that we used in our particular study. Thank you so much for giving us an opportunity to participate in presenting our study, and for listening to our study as well. Thank you so much.
A very warm greeting to one and all present here. Myself, Darshan D, speech language pathologist and audiologist, JSS Institute of Speech and Hearing, Dharwad. Today I'm here to present our work. Entitled with Impact of COVID Infection on Swallowing, a preliminary study. As we all know that COVID-19 have embarked or thrived all our lives in our lifestyle, health, and overall quality of life. Yes. So what is it COVID-19? All of us are hearing it from last couple of years. COVID-19 is an infectious disease caused by the severe acute respiratory syndrome coronavirus. It's over 24 million people globally. Patients with COVID-19 may have multiple organ system pathology and as a result often require prolonged periods of rehabilitation. When we look back to the pathophysiology of COVID-19 emerges and results dysphagia as a sequelae of the disease due to viral progression. After considering all these points, this dragged our attention that there must be a relationship between COVID infection and swallowing disorders. So when we started reviewing some of the literature evidences which have been reported recently in Western countries, we found that there is a dysphagia or it might be associated with COVID-19. Many of the patients presenting with dysphagia in acute care hospitals. The impact of intubation and extubation, proning, tracheostomy, and critical illness become apparent in these patients with significant burden of dysphagia. And one of the study done in UK tertiary hospital also reported the high prevalence of dysphagia in patients admitted with COVID-19. All these factors or the research evidences suggested us or dragged that the global pandemic demands for reporting each clinical observation. The role of swallow rehabilitation in patients with COVID-19 has not been reported despite its high prevalence. Dysphagia as a result of COVID-19 are yet to be understood as not well explained, and studies on Indian population are very minimal or scanty. So considering all these points, the present study was conducted to assess swallowing problems in COVID patients with the ambition to investigate the swallowing problems in individuals affected with novel corona by administering dysphagia handicap index, and also to compare the findings during the active infection period and post-recovery period. Coming to our methodology, we consist around 30 participants, which 18 were males and 12 females between the age range of 25 to 50 years, and the participants were divided into two groups based on the severity of the CT scores. If the CT score comes between 1 to 15, put them to mild severity, that is group 1, and the CT score with the range of 16 to 25, put them to severe group, that is group 2. Detailed information and consent was obtained from each of the participants prior to the actual study. Swallowing difficulties were quantified using dysphagia handicap index. When it comes to the procedural aspects, the administration of dysphagia handicap index was carried out in two phases. Firstly, at the active infection period, that is within the 48 hours of confirmed diagnosis of COVID-19 infection, and then after 1.1 month of post-recovery or post-discharge. Dysphagia handicap index, it is a screening tool which is user-friendly and clinician-friendly, which can help us to determine the presence or absence of swallowing impairment in any medical ailments. So it is a 25-item questionnaire, clinically efficient, sensitive, robust, patient-reported outcome tool, which measures the handicapping effect of dysphagia by assessing the physical, functional, and emotional aspects of individual lives. It consists responses like never, sometimes, or always to each statement and rated their self-perceived dysphagia severity on a 7-point rating scale. The obtained scores ranges between 0 to 35 can be considered to be normal, 36 to 60 mild, 61 to 90 moderate, and above 90 as severe. And it has reported clinical sensitivity of 82% and specificity of 72%. Thus, by considering all these things, we found that as a preliminary work, we can just rule out by administering dysphagia handicap index the presence or absence of swallowing disturbances in COVID individuals. So when it comes after obtaining the data, the data suggested us as reported or shown in the graphical representation in both the groups at the active period, there is a swallowing issues, but people with more severe CT scores are showed a severe or the maximum dysphagia handicap index scores in comparison to group 1. But post-recovery, group 1 people, that is minimal CT score people, showed no or almost normal swallowing abilities in compared to group 2, but severe people showed the mild to minimal to mild or mild to moderate way of swallowing disturbances. The obtained scores were subjected to Shapiro-Wilk test to check the data normal distribution of the data, but it suggested that the data were found to be non-normally distributed for all the domains of DHI in both the groups. Thus, non-parametric test like Wilcoxon sign rank test was administered. Even that results suggested the significant difference in both the groups across the conditions. Thus, the results indicated improvement in swallowing abilities post-recovery, but the group 2 severe participants reported minimal swallowing problems which are persistent. Looking into all these things, we can infer from our study that individuals infected with coronavirus encounter breathing difficulties, which affects voice, swallow, and communication abilities. Thus leads to dysphagia based on the extent of infection or lung involvement. The swallowing difficulties may resolve once infection subsides or persist post-recovery, leading to alteration in their swallowing abilities. By this, I would like to conclude my presentation by telling the take-home message that swallowing disorders is found to be prevalent in COVID infection related to respiratory problems. The present observation indicates the presence of swallowing issues in patients with COVID-19 virus. So highlights the importance of early identification and early intervention for swallowing disturbances. And it also infers the long-standing effect of novel coronavirus on swallowing abilities in infected patients. At last but not the least, it also emphasizes the need of detailed evaluation to support the client to overcome swallowing problems and promote better quality of life. I would like to take up this opportunity to acknowledge all our clients and their caregivers for their immense support throughout the study. These are our references. Thank you all. Have a great day.
Thanks to all the participants for their efforts and to the delegates who have been with us today. We come to the end of the award session here in Hall B. Delegates are requested to move to Hall A for surgical demonstrations and the Senior Consultant Award paper presentations. Thank you once again.
Stop the live stream.